The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So now let's go to your lung and pleura. So atelectasis, it means collapsed lung. So we have 3 types, your resorption, compression, and contraction. So pag may ang resorption, you have something that obstructs your airway and therefore air cannot go in, hindi ma-ventilate yung segment na yon, no? Kaya nagko-collapse yung part na yun ng lung. Now, for your compression, there is something in the pleural cavity that compresses your lungs, no? Kaya siya nagko-collapse. And then for contraction, it has something to do with your fibrosing disorders. Now, for your resorption and contraction, the late phase, no, there's ipsilateral tracheal deviation kasi nakahatak niya papunta sa kanya, no, yung mediastinal structures. Now, for contralateral, since there is compression, no, since there is compression because there is something in the pleura of the deceased lung, pinupush niya papunta sa contralateral side yung mediastinal structure. So, yun yung pinagkaiba, okay? Now, the complication of this is if you have a collapsed airway, if you have a collapsed alveoli, no, syempre hindi yun ma-ventilate and therefore you will have low oxygenation because of ventilation-perfusion mismatch, and those atelectatic segments, hindi mo makiklear yung secretions doon, so meron kang risk for infection. Okay. Now, pulmonary edema, we're going to skip that kasi na-discuss na natin yan sa chapter 3. Okay, now let's go to acute lung injury or ARDS. Pag acute lung injury, it's the abrupt onset of hypoxemia and bilateral pulmonary edema in the absence of heart failure. So, it shouldn't be, the heart failure shouldn't be the cause. Now, severe ALI is called ARDS, no, or acute respiratory distress syndrome. So, as you can see in your etiology, no, yung common theme nila is they can injure your endothelium, no? They can injure your endothelium, they can injure your epithelium. So basically, dun siya nagsa-start, no? When you injure your endothelium and your alveolar epithelial cells, well, basically magti-trigger yun ng inflammation and cell death. Now, the carnage na iniwan ng inflammation, no? Yun yung nagiging hyaline membrane. Nag-organize yun into a hyaline membrane and it coats your alveolar walls. And therefore, kagaya ng sa neonatal RDS, meron kang increased diffusion distance kaya ka nagkakaroon ng hypoxemia. Also, when you kill your type 2 pneumocytes, no, you will decrease your surfactant and that can cause alveolar collapse, no, or atelectasis, which can further aggravate the hypoxemia because of low ventilation, no? Now, ang characteristic lang naman sa ARDS yung hyaline membrane, no? So yun yung tatandaan nyo. And ito nga yung mga may acute onset of respiratory distress and hypoxemia, no, na refractory to O2 therapy. And you have on X-ray bilateral lung infiltrate. So yun yung mga yun yung clinical features niya. Okay? For obstructive and restrictive lung diseases, for obstructive, your air can't go out. So, hindi naman ibig sabihin na meron kang organic obstruction. It's because there is resistance to airflow. Kaya hindi makalabas yung hangin. Now, for your restrictive, the air can't go in because of limited lung expansion. So, here is a photo ng lung volume studies, no? So, meron tayo sa leftmost yung normal. Yung restrictive, as you can see, you have limited lung expansion. So, therefore, all of your lung volumes are decreased, no? Yan. While for your obstructive, ang nangyayari, your lung volumes are increased because there is air trapping, no? Because there is air trapping. Now, yung obstructive lung disorders mo, the forced expiratory volume in 1 second over the FVC is characteristically decreased, like less than 0.7. It's because there is marked decrease in expired air, no? Kasi nga air can go out, 'di ba? Kaya mababa yung FEV1 mo. And that makes the ratio even lower, no? While in your restrictive volume, since all volumes are affected, basically preserve yung FEV1 FVC ratio mo. Okay? Now, for your obstructive lung diseases, we have your COPD. Dalawa yung nandun, yung emphysema and your chronic bronchitis. Now, yung emphysema, you destroy, no, your air spaces. Okay? Ano nangyayari? Pwedeng smoking, pwedeng alpha-1 antitrypsin deficiency. So, pag smoking, it's centriacinar emphysema. Pag pan-acinar, alpha-1 antitrypsin deficiency. So, for centriacinar, ang nangyayari, the cigarette smoke injures your, causes the alveolar wall destruction, while your alpha-1 antitrypsin deficiency, your alpha-1 antitrypsin kasi is a protease inhibitor, no? So if you have the deficiency of that, then you have an unbridled protease activity and therefore it can destroy your alveolar walls as well. So morphologically, they have a lot of air inside them, no? And if you look at them under the microscope, you will see large air spaces kasi nasisira yung alveolar walls, kaya nagiging isang malaking large airspace lang siya. Now, why is this bad? Also pala, wala masyadong fibrosis in your emphysema. Now, why is this bad? Kasi yung elastic recoil ng lungs ay nakadepende dun sa interconnections ng mga alveolar sacs. Now, if you destroy those interconnections, then basically, you decrease, no, the elastic recoil. So, hindi siya maka-expire ng air completely, no? So that's the obstruction in your emphysema. Now, for your chronic bronchitis, the definition is this: no, persistent cough with sputum for at least 3 months in at least 2 consecutive years in the absence of any other cause. So again, kapareho ng emphysema like in other COPDs, no, smoke talaga. Smoke talaga is one of the most important causes, no? So anyway, pag chronic bronchitis, di ba, may sputum production. So the pathogenesis has something to do with a lot of mucus things, no? So anyway, ang nangyayari dito, your noxious substances will cause chronic inflammation, no? Will cause persistent inflammation of your airways, and as a response, no, your mucous glands will increase, no? Kaya ka nagkakaroon ng maplemang ubo. Okay? So yun. And you know that when something is chronically inflamed, alam mo na, may mononuclear infiltrates, no? May fibrosis na kasama, and because of the growth factors in the chronic inflammatory environment, it's the mucous glands that proliferate, no? Kaya nagkakaroon ka ng ganyan. Now, if something is chronic, you can have bronchiolitis obliterans. We're going to discuss that later. And when something is chronically insulted, di ba, no, na tissue, pwede ka magkaroon ng metaplastic epithelium and dysplasia. So, yeah. So, in terms of clinical presentation, ito yung table, sa uluhin nyo na lang. But basically, yung mga bronchitis patients, they're called blue bloaters, and yung mga bronchitis patients, ang clinical picture nila, ubo na productive, no? In keeping with, of course, the pathogenesis. While your emphysema, sila yung mga hirap na hirap huminga. And they're called your pink puffers. Okay? Now, obstructive lung diseases include your asthma, no? Ang i-discuss natin dito, atopic asthma. I won't dwell so much on your asthma because it's basically a type 1 hypersensitivity reaction against inhaled antigens, no? So basically, ganun siya. But I want you to know that asthma is a chronic disease, and therefore you can have airway remodeling changes as follows, no? But pwede ka ring magkaroon ng acute attack ng asthma na severe, no? And that's what you call your status asthmaticus. In which case, kapag status asthmaticus ka, you have overinflated lungs with thick tenacious mucus plugs, no? Plugging the airways, kaya hindi makalabas yung hangin. So yun yung finding. And also in your asthma, you have your characteristic sputum exam findings, your Kirschmann spirals, which are extruded mucus plugs, your Charcot-Leyden crystals, which are derived from your eosinophil protein galactin-10, and your 3D clusters of bronchial epithelial cells called your Crayola bodies, as well as eosinophils, of course, no? So, alam nyo naman kung anong manifestation ng asthma. Diyos ko naman. Hindi ko na i-discuss yan. Now, bronchiectasis. Bronchi, yung bronchial, no? And then, ectasis. So, pag ectasis, ibig sabihin, or ectasia, ibig sabihin, dilation. So, there is prominent dilation. Ang nangyari kasi dito, you have condition that promotes infections. No, for example, your cystic fibrosis, your primary ciliary dyskinesia because of impaired mucociliary clearance of your secretions, and associated with your PCD is your Cartaginer syndrome, consisting of your bronchiectasis, sinusitis, sinus inversus, and sperm dysmotility. As you can see in this radiograph, hindi nakaharap sa left yung heart niya. Nakaganon siya sa right. So, meron kang situs inversus. Okay, so basically, ang nangyayari, if you don't have, if you have impaired clearance of secretions, that can be a fertile ground for your infection. And since hindi mo nga maklear yon, you will have persistent infection. And that will destroy your airways, leading to permanent dilation. So anyway, wala namang special about your bronchiectasis in terms of morphology. Basically, pag acute inflammation with intense acute inflammation and destruction of whatever the surrounding environment is. And then pag chronic, syempre may fibrosis and dilation of your airways. So these are the common etiologic agents no na nakukulture natin sa bronchiectasis. And of course, since meron kang infection, alam mo naman kung anong clinical presentation niya. Usually, marami kang plema, no? And you can have hemoptysis because kapag nag-erode yung, in the same way like TB, kapag nag-erode yung, or na-involve yung bronchial vessels in the inflammatory process, then pwedeng magkaroon ka ng bleeding. Okay? Kaya yun yung hemoptysis. Now, let's go to your restrictive diseases. So, yung restrictive diseases natin, ito yung mga fibrosis, no? Ang common theme nito ay fibrosis. So, anyway, ang end stage ng mga restrictive diseases ay yung honeycomb lung. So, you have a diffuse lung scarring. Now, a scarred lung, of course, magkakaroon yan ng increased pulmonary vascular resistance. And therefore, yan yung mga cause ng cor pulmonale, no? Okay, so let's start with your idiopathic pulmonary fibrosis. Well, ang tatandaan nyo lang naman dito, pangit ang prognosis niya. Okay? Pangit ang prognosis ng IPF. 3.8 years lang ang median survival. So, like, ang pathogenesis kasi nito, simple lang. Basically, continuous injury, no? Continuous injury and then fibrosis. No? Ganon. Basically, ganon. And then, smoking pa rin naman ang most important risk factor, no? And the morphology is your usual interstitial pneumonia. It's called like that. So your early lesions are your fibroblastic foci as shown here, no? And then yung honeycomb fibrosis, yun yung late stage. So meron kang disruption ng lung architecture. So hindi mo nasisira yung lung architecture. Okay? And you see different ages of these lesions across the lungs. So basically, respiratory insufficiency, no, yung presentation ng mga restrictive lung disease. Compared to non-specific interstitial pneumonia, no, ang non-specific interstitial pneumonia, same age lang ang lesions, walang destruction ng lung parenchyma, and better ang prognosis compared to your UIP. Okay? Now, for your cryptogenic organizing pneumonia, nabanggit yan kanina sa chronic bronchitis, no? Na pwede kang magkaroon ng cryptogenic organizing pneumonia in the long run. Kasi ano nga siya, parang long-term effect ng or a response to against infection in inflammatory lung disorders. So basically, ang nakikita mo sa kanya, you have your Mason bodies plugging your airways. And then for your pneumoconiosis, okay, ang common pathogenesis nila, meron kang mga inorganic particles na lalanghap mo yon, they go to the distal air spaces, they're phagocytized by your alveolar macrophages, your alveolar macrophages get activated, and then nagkakaroon ka ng inflammation and destruction of your airways. So basically, ganon. No? For your coal workers, ang exposure mo ay coal dust. So tignan mo sa trabaho nila, no, kung na-expose ba sila sa coal dust. Now, the clinical presentation can range from a very to an asymptomatic one, no, na meron ka lang carbon pigment in your lungs, or can be as severe as progressive massive fibrosis because of the coal deposition. So that's your complicated coal workers pneumoconiosis. Okay, it's not associated with your TB and lung cancer. in contrast to silicosis. Kasi ang silicosis increase susceptibility to TB and lung cancer. So it's the most common pneumoconiosis and chronic occupational disease worldwide. And of course, silicosis. So silica ang exposure, mga quartz, and these are some of the jobs or occupations na exposed ka sa silica. So ito yung mga titignan nyo sa history, no? So ang itsura niya, meron kang ito yung lesion mo. So, yung central mo is collagen, and then meron kang nakapaligid na dust-laden macrophages, no? And inflammatory cells in your fibroblasts. Okay? Now, for asbestosis, this is an example of an asbestos body. So, pag nalanghap mo yan, pupunta yun sa air spaces mo, and then, magkakos ng inflammation and airway damage. Okay? So, yung asbestos, no, aside from pleural plaques and pleural effusions, it can increase the risk for mesothelioma and your lung cancer. For your sarcoidosis, this is a granulomatous disease. Ang pathogenesis niya ay unknown, pero presumably a cell-mediated response kasi nga granulomatous, no? Morphologically, no, non-caseating granuloma siya. So, ang TB kasi caseating, di ba? Ang sarcoid, hindi. And these are your inclusions in your giant cells. You have your Schaumann and your asteroid, as shown here. Now, the common organs involved are your lymph nodes, followed by the lung. So, most common ang lymph nodes, and then followed by the lung. Okay? And the most common cause of death is pulmonary fibrosis. Well, kasi nga, granulomatous disorder to, pag nag-heal to, magiging fibrosis yun, no? And then, of course, pag meron kang fibrosis, you will end up with cor pulmonale. So, pag hypersensitivity pneumonitis naman, basically, meron kang triggers, no? Ito yung mga trigger na nakalagay dyan. So, it's a type of hypersensitivity reaction to these environmental triggers with a bit of an antibody component. So, basically, ang meron lang naman dito sa hypersensitivity pneumonitis, it can look like pneumonia in the acute phase. Pero papansinin mo, hindi siya nag-heal with your antibiotic intake. So, you have to check the history kasi baka mamaya, yung trabaho niya, meron siyang exposure doon sa mga organic na ganyan. So, pag inilayo mo siya doon, hindi yun na-atake. Okay? So, for smoking-related naman, we have your desquamative interstitial pneumonia. So, basically, ang nakikita mo lang naman doon, you have a collection of your smoker's macrophages within your alveolar cells. Kaya mukha siyang, kaya sinabing desquamative, no? Kasi mukhang nagde-desquamate yung alveolar lining, no? Kaya ganon. Okay? And then kapag meron ka ng significant fibrosis, edi na yon, respiratory bronchiolitis associated interstitial lung disease. It can increase the risk for TB and lung cancer. Okay? So, for your pulmonary hypertension, it's defined as a mean pulmonary artery pressure of at least 25 millimeters mercury at rest. And these are the causes, no? Pwedeng autoimmune, pwedeng gawa ng heart failure, no? If you have left-sided heart failure, then basically magkakaroon ka ng pulmonary congestion, and if it becomes chronic, then you will have pulmonary vascular remodeling and pulmonary hypertension. Now, for your group 3, the primary intrinsic lung diseases, no? Yun. Yung mga intrinsic lung diseases mo, pag halimbawa mga bronchitis, chronic bronchitis, ganyan, yung mga fibrosing disorders, you can have vascular remodeling din. No? Kaya nagkakaroon ka ng pulmonary hypertension. And then for your chronic thromboembolism, now these can provide obstruction which can cause increased pulmonary vascular resistance, no? And group 5 yung mga unclear. So basically, ang nakikita mo sa pulmonary hypertension is medial hypertrophy. As you can see on the left photo, ang nipis ng media, but dito grabe ang kapal-kapal ng media. And kapag may ganyan, there's increased resistance at the level of your pulmonary vasculature. Therefore, you will eventually have right ventricular hypertrophy. Now, for the infections, for the pneumonia, I will leave this to you to peruse. Okay? Kaya nyo na yun. Tandaan nyo yung mga most common. But anyway, ang morphologic patterns ng inyong pneumonia, no? Two major yan. May bronchopneumonia, may lobar. Yung lobar na sa left, nun sa picture, consolidation siya ng entire lobe, no? Or a large portion of a lobe. Basta buo siya na ganun. Ang bronchopneumonia naman, patchy. Okay? Now, your lobar pneumonia, it's commonly caused by your strep pneumo, and it undergoes under 4 stages. Your congestion, red and gray hepatization, and then eventually resolution. I will leave that to you to read. No? Now, for your bronchopneumonia naman, ang nangyayari, you have your neutrophil-rich exudate within the alveolar space. Okay? Now, for your viral pneumonia, the location of the inflammation is usually interstitial and usually mononuclear yung inflammatory infiltrates. While for chronic pneumonia, if you have an immunocompetent host, usually granulomatous, no? Kasi mga TB and fungi usually yung kanilang etiologic agent. Okay? So ano ba ang clinical features ng pneumonia? Well, usually may lagnat sila, no? May lagnat, maplemang ubo, and then may dyspnea. Now, if you have consolidation, you can have increased tactile fremitus, but if you have effusions, no? But if you have effusions, you can have decreased tactile fremitus. If you auscultate, no, your lung fields, you can have crackles kasi may secretions ka doon. And then depending on the pattern of pneumonia, kung lobar or bronchopneumonia, then doon magde-depend yung X-ray findings. So the complications of that include your lung abscess, empyema or a purulent pleural effusion, and the bacterial dissemination. You know that your lung is a very vascular organ, and the bacteria can access the systemic circulation through the lungs. Now for your lung abscess, di ba? Suppurative necrosis of your lung tissue. So, usually, nagpo-form sila ng isang malaking suppurative necrosis and then nare-resolve yun eventually, and then nagkakaroon ka ng mga cystic spaces. Now, those cystic spaces can be a ground, no, for the development of your aspergillosis, no? Kung i-recall nyo yung chapter 7 nyo. Now, the most common cause of your lung abscess is aspiration, and it usually happens in the right lung, no? In the right lung. Bakit? Kasi yung anatomy ng right lung, mas paganon siya. Mas pa-vertical, no? Yung kanyang orientation ng airway. Okay? Now, lung cancer. Okay, lung cancer is the most common carcinomas are the most common primary lung tumors, no? And it's the most common cancer in the world and most common deadly cancer, no? Okay? Now, smoking is the most important cause, and there are a lot of other causes, but smoking is the most important. Now, these cancers, they have precursor lesions, but remember that your precursor lesions do not always progress to invasive cancer. Okay? So, for your lung carcinoma, generally, ang most common symptom ay cough. Of course, you have cancer cachexia, no, and all that jazz. Okay? And then, ayan, yung paraneoplastic syndromes, no, common siya in your small cell carcinomas. Binanggit natin yan dun sa chapter 6 sa neoplasia. So these are your paraneoplastic syndromes in your lung carcinoma. Okay? Now let's go to the types. The most common histologic type is your adenocarcinoma, and it usually arises at the peripheral so mga distal airway siya. Peripheral yung lesion. Okay? Can be associated with smoking but low. No, it's the most common type in your never smokers. And pag sinabing adeno, it's gland. So makakita ka ng glands, no? Ayoko na masyado mag-dwell into the details of the morphology. It's too complex. Basta meron kang glandular differentiation. Can produce mucin or not, no? Now, these are the precursor lesions, no? And these are the mutations, okay? Di ko alam kung nice to know itong mga mutation. Pero sige, no? Usually may KRAS, may EGFR, may ALK, no? And your EGFR is important because it is the most common mutation in your non-smokers. It's also prognostically important and is a targetable mutation, meaning pag may EGFR mutation ka, pwede kang mag-anti-EGFR, no, na gamot. Okay? Another targetable mutation is your ALK. Now, if you have KRAS mutations that has a worse prognosis. Okay? Now, for your squamous cell carcinoma, it's the second most common histologic type. Usually central yan, and mas associated siya with smoking. Now, alam nyo na naman ang squamous cell carcinoma, so invasive, malignant nests of squamous cells na invasive. Pwede sila magkaroon ng keratinization. Yan, nakikita nyo dyan, may keratin pearl. No? And the mutations involve your TP53, CDKN2A, and your FGFR1. For your small cell, ito yung pinakamasaklap, no? I mean, kung magkakaroon ka ng lung cancer, wag lang small cell. Okay? So, it's the third most common histologic type. It's also central, no? It's also central. So, medyo nasa mga mainstem bronchi yung mga yan, or basta nasa proximal airways. And it's also, it's associated with, highly associated with your smoking. Now, yung small cells na yan, ayan, you have your small, round, or spindle-like cells. May nuclear molding. You have salt and pepper chromatin, typical of your neuroendocrine neoplasms. But you have a lot of mitosis here, no? Marami kang nakikitang mitosis, and necrotic din yung mga tumor na yan. Being a neuroendocrine neoplasm, no? Your small cell lung cancers is the histologic type, no, that is most associated with the development of your paraneoplastic syndromes, like your syndrome of inappropriate ADH secretion, Cushing syndrome, and your and Cushing syndrome, no. The mutations, well, alam nyo na, pag malala, usually TP53 and RB, the main tumor suppressor genes, no, yun yung mutation. Now, large cell carcinoma, pag hindi mo siya makarakterize, no, pag hindi mo siya makarakterize at the end of the day, then it's a large cell carcinoma. That's just it. Okay, now this one is a neuroendocrine tumor that is not malignant, no? It's not malignant, so it's a carcinoid or a neuroendocrine tumor. So it can be central or peripheral, pero usually central siya, no? Yung bronchial carcinoid na tinatawag. So these are your low grade, very very uniform looking neuroendocrine cells with characteristic salt and pepper chromatin in a lot of architectural patterns. Now, they are capable of producing bioactive substances that can cause carcinoid syndrome. And we're going to discuss that later on. Siguro sa mga GIT na lang, no? But remember that the most common lung tumor is metastasis. Okay? The most common primary lung tumors are lung carcinomas, but the most common tumor is metastasis. And therefore, kapag meron kang mass sa lungs, you always have to rule out mets. Okay, now pleura. So ang pleura natin, it's lined by mesothelium, and the mesothelium of course produces your serous fluid, no? So that's why your pleura meron siyang fluid, no? Na mga 15 ml na serous, no? And kapag sumobra doon, that's your pleural effusion. Now basically, pinag-aralan na natin yung mechanisms niya in your chapter 3, so I will skip that. No? But there are types of your pleural effusion. You can have your inflammatory effusions and your non-inflammatory effusions. Remember that and these are the most common. These are the most common conditions. Ang gusto ko lang i-point out dito, when you have a hemorrhagic, when you have a hemorrhagic effusion na inflammatory lalo na, please rule out tumors. No? Please rule out malignancies. And then, and the most common na non-inflammatory na transudative, no, is your heart failure. And usually the most common inflammatory is your na infectious cause is TB. Now for pneumothorax naman, imbis na fluid, air naman, no, pneumo. So air naman. Air in the pleural cavity. So kapag meron kang mga emphysema na nag-rupture, no, or kaya TB, syempre, you know, your TB is destructive, no? It's a destructive lesion. Pwede ka magkaroon ng airway destruction, and then pwedeng yung destroyed airway na yon mag-open up to the pleural cavity, so pwede ka magkaroon ng escape ng air papunta doon. Okay? So, these are the causes, no? Nakalagay naman dyan. But ang gusto ko lang i-point out is yung tension pneumothorax. So, if you have tension pneumothorax, masyadong matindi yung iyong pneumothorax, no? And it can compress the mediastinal structure. So, ang mangyayari niyan, walang makakapasok na blood, no, sa heart kasi nga na-compress yung mediastinal structures. And that is a type of obstructive shock, no? Under your cardiogenic shock. Kasi you obstruct the normal blood flow through the heart. To the heart, no? Kaya ang tawag doon ay obstructive shock. And because the heart cannot pump blood, no, and cannot fill itself with blood, then that is under cardiogenic shock. Now, an interesting thing about your pneumothorax is that nagpo-produce siya ng pleural effusion, no? And it's rich in eosinophils. So that is what you call your reactive eosinophilic pleuritis. Now, for your pleural tumors naman, you have your pleural mesothelioma. Nabanggit ko kanina sa pneumoconiosis that it is associated with your asbestos exposure. No, morphology is not much of a problem. Masyadong toxic na for you. Pero tignan mo yung gross, no? Tignan niyo yung gross. Yung pleura, no? Ang laki na ng pleura, it's very thickened and it invades the surrounding lung parenchyma already. So ito yung tumor niya, yung white na naka-encase na ini-encase niya yung lung, no? And then your pleura, your pleura can be involved by different tumors. So it's actually more common than your primary tumors, and the most common sources are your lung and your breast. So usually nagkakaroon ka ng pleural effusion dito with malignant cells. So check your history kung may primary tumor ba, no? Okay, and that ends your lung and pleura. Let's now go to head and neck. So, yung dental and related disorders, skip na natin yan. Pati itong aphthous ulcers. Pwede nyo namang basahin yan. Ito, itong mga infections, no, yung herpes simplex saka yung candida, na-discuss naman natin to sa may infectious diseases. So, hindi na rin ako masyado magdedwell dyan. But I just want you to remember na yung mga HSV, herpes is forever. Parang diamonds nga daw. No? Kasi, di ba nga, they exhibit latency. Now, they can reactivate, and these are the following triggers. No, your UV light, temperature extremes, immunosuppression, infections, no, pregnancy and menses. So, minsan makikita nyo yung history sa cases nyo, may painful vesicles, no, after mag-beach, no, kasi nag-resurface, no, or nag-reactivate yung kanilang herpes. Okay? So, yun. Now, for your leukoplakia, so this is a white patch that cannot be scraped off. Okay? So, yan yung itsura niya, leukoplakia. Now, kung pre-malignant lesion yan, ibig sabihin, and you know that yung lining sa oral cavity ay squamous, then ibig sabihin, may dysplasia dun sa epithelium. Pero dysplasia pa lang siya, kasi nga pre-malignant eh. So, dysplasia pa lang siya, so intraepithelial pa lang. No? Now, for erythroplakia naman, red siya kasi may vasodilation and may vasodilation, no? Kaya siya red. Now, yung erythroplakia, it's more ominous than your leukoplakia kasi yung mga histologic changes na nakikita mo sa erythroplakia are more malala, no? Yun lang. Okay. Now, for squamous cell carcinoma, yan, it's the most common head and neck cancer. Now, meron tayong dalawa, no? Your oral cavity and your oropharyngeal. Yung oral cavity, ibang risk factors niya. Siya yung may sa smoking, alcohol, nganga, ano, yan. Okay? And usually, yan, nangyayari yan sa oral cavity. So, mga ventral tongue, floor of mouth, yan. And the usual histology is keratinizing. Okay, the usual histology is keratinizing. As you can see in this photo, may squamous pearls ka dyan, may keratin pearls ka, so keratinizing squamous cell carcinoma. Yan. Now, your oral cavity squamous cell carcinomas tend to be aggressive. For your oropharyngeal naman, ang risk factor niya hindi yung mga alcohol smoking kineme, no? Ang kanya risk factor niya major, no, is high risk HPV. Okay? So, basically, yung higher number of oral sex partners. Okay? So, pag oropharynx, so sa tonsil, sa tongue base, no, doon siya nangyayari. And the morphology is usually non-keratinizing. As in this photo, wala ka nakikitang keratin pearls, di ba? Squamoid cells siya, yes, but then walang keratinization. Okay? So, dahil HPV-related yan, no, positive siya sa P16, which is a marker of your HPV infection. Because the viral protein E7 of your HPV, no, HPV, ini-increase niya yung P16 levels mo, no? Kaya nagiging marker siya or surrogate marker siya ng HPV infection. Okay, and the prognosis is better, no, than your oral cavity squamous cell carcinomas. Let's go to your odontogenic lesion. So basically, these are your your cysts, no? Starting with your odontogenic cysts, we have 3. Your dentigerous, just take note of the history. Impacted or unerupted tooth dapat, no? So, it's a true cyst. So, may squamous epithelium, no, na lining, and then may a bit of stromal chronic inflammation. Okay? It can recur with incomplete excision, so you have to remove it completely. And it can progress to ameloblastoma. Now, for your odontogenic keratosis, it's special. It's associated with your Gorlin syndrome, no? with your Gorlin syndrome. Okay? So, kanya, squamous cyst din to. Pero, yung surface niya ay corrugated. So, ganun-ganon. Okay? And then yung radicular cyst nyo, ang characteristic history niya, may dental caries, no? May dental caries. And therefore, you would expect the cyst to be, to have, no, an intense inflammatory reaction. Okay? So, it's also called periapical cyst or apical cyst. Compared, in contrast to your, dentigerous cyst, your radicular cyst or periapical cyst will not progress, no, to ameloblastoma, a tumor, no, an odontogenic tumor. It will not progress to that. No? But syempre, dahil may inflammation ka, no, and may history ka ng dental caries, it can become an abscess. Now, for your odontogenic tumors, we're going to discuss two lang, your odontoma and your ameloblastoma. So, your odontoma is the most common odontogenic tumor. Ang pinagkaiba niya sa ameloblastoma, ang odontoma ay may ectomesenchymal differentiation. Ibig sabihin, meron kang enamel and dentin, as you can see in this photo. So, yung bright pink dyan, yung dentin, and yung mga light purple dyan, yung enamel. So, pag ganyan yung tumor, odontoma yan. Okay? Yung ameloblastoma naman, island siya ng ameloblastic epithelium, no, na nakapalisade around a stellate reticulum. So, yan yung itsura niya. Now, ang pinagkaiba niya sa odontoma, ang ameloblastoma, wala siyang ectomesenchymal differentiation. So, walang enamel, walang dentin. Okay? And since this recurs with incomplete excision, the treatment is your wide excision. Now, for upper airway, starting with rhinitis. Alam nyo naman na pwedeng infectious or allergic ang cause ng rhinitis. And if you have long-standing rhinitis, you can have nasal polyps like this. So, basically, they're just polypoid masses of inflamed mucosa, nor inflamed nasal mucosa. So, yan. Yan yung ano niya. Now, because of these polyps, they can present with nasal congestion, no? Or obstruction. Now, pharyngitis, tonsillitis, alam nyo na yan. Ang gusto ko lang i-point out dyan, if you have a unilateral tonsillitis, no? Unilateral tonsillitis. If you have a unilateral tonsillar enlargement, you might want to biopsy that. Kasi kung chronic tonsillitis yan, 'di ba? We have chronic hypertrophic tonsil. So malaki dapat yan pareho. Pero kapag mas malaki yung isa, tapos as in significant yung size, then that is unilateral tonsillar enlargement and you want to rule out your tumors, no? But for your tonsillitis, ayan, they can cause obstructive sleep apnea, no? Pag malaki. Okay? Now, tumors, you can have sinonasal tract angiofibroma. Okay? Now, characteristically, it occurs in young adolescent males or in patients with familial adenomatous polyposis. Now, it's an angiofibroma. So, marami kang vessels na nakikita dyan in your picture and then on a fibrous background. Since marami yung vessels, it can bleed. No? It can bleed. It's also locally aggressive, kaya ang yung differential dyan is a cancer, no? Tapos yung sinonasal papilloma naman, we have three types: your exophytic, inverted, and oncocytic. This picture right here is an inverted papilloma. Pag inverted papilloma, paloob yung growth, kaya nandun sa loob yung mga nests. Pero benign yung benign yung cytology niya, yung itsura ng mga cells. Okay? So, it can present as a mass din. So, pwede ka magkaroon ng obstruction, no, nasal congestion. And then, for your nasopharyngeal carcinoma, ito may may geography. No, meron siyang geography association. So, pag children, Africans, pag adults, Chinese. And then, it's associated with your Epstein-Barr virus together with your Burkitt lymphoma and some types of your Hodgkin lymphomas. And some foods, no? Also smoking. Okay? So, it's the most common site is your Rosen-Muller fossa. And the morphology is squamous cell carcinoma. Pero it can be keratinizing or non-keratinizing. And the most common is your undifferentiated subtype. So, undifferentiated, meron ka lang dyang nests of your tumor cells on a lymphoid background, no? And mahirap naman i-tell kung ano siya. Okay, kaya siya sinabing undifferentiated subtype. So, the clinical manifestation of your nasopharyngeal carcinoma, nasal obstruction. Syempre may mass, so may nasal obstruction. May epistaxis, no? So basically, ang dami mong differential dyan. Pag may epistaxis, yung nasopharyngeal angiofibroma. Nasal obstruction, ano pa? Nasal polyp, inverting papilloma, ano pa? Nasopharyngeal angiofibroma, pwede rin, no? So look for your cervical lymphadenopathy, okay? In your nasopharyngeal CA. And of course, dahil pwede ngang mag-present yan as nasal obstruction, yung mga nasal masses nyo, binabiopsy talaga yan, no, to rule out cancer. Okay? So, the histology has a bearing in prognosis because the undifferentiated is the most radiosensitive, no, while the keratinizing is the least radiosensitive. For your laryngitis, na feeling ko magkakaroon na ako any minute now. Charot. Hindi pala. Reactive nodules pala yon. So anyway, these are the causes of your laryngitis. So may infectious causes and meron din tayong non-infectious causes like your allergy, no, GERD, no, if you hear the entity LPR, no, laryngopharyngeal reflux, and also your smoking because it can cause irritation, no. So alam nyo naman na ang presentation ng laryngitis ay voice loss and area obstruction pag magang-maga, no? And remember that children have smaller larynxes, and kapag nagka-laryngitis sila, it can be very problematic because they're very, very prone to area obstruction. So be careful. Reactive nodules, this is something that I think magkakaroon ako. Huwag naman sana. Okay? So, voice abuse, like the one I'm doing now, is one of the causes of your reactive nodules as well as your smoking. So, ayan ang itsura ng vocal cord nodule. Ayan. No? Now, this one is unilateral. So, minsan tinatawag nila ito pag unilateral vocal cord polyp. Pero kapag bilateral, vocal cord nodule. But anyway, pare-pareho lang naman silang reactive nodule at the end of the day. So, basically, ano lang naman siya? Loose myxoid tissue. So, ito yung stroma niya. And then, benign naman yung epithelium na covering. So, no worry. Wala namang kailangang ipag-worry. No? Kahit benign siya, it never gives rise to cancers. No? Virtually never. The problem is it can present with hoarseness. And that is also a manifestation of laryngeal carcinoma. Kaya usually, yung mga hoarseness, talagang wino-work up sila to rule out cancer. So, yun. Now, squamous papilloma and papillomatosis, it's the most common benign laryngeal epithelial tumor. Syempre may mga papilloma yan, so alam mo na, human papilloma virus, pero low risk, no? Pero low risk. Okay? So, papillary ang itsura, so may finger-like projections covered by squamous epithelium, no? Na benign naman ang itsura, but you have isolated coelocytes. Ito yung mga parang viral cytopathic effect ng human papillomavirus infection. So meron kang perinuclear clearing and then parang racinoid yung kanyang nucleo. So yun yung mga coelocytes. More about that sa repro, no? Sa reproductive system na lang. Okay? So it can be solitary or multiple. Pag multiple papillomatosis ang tawag, hoarseness din ang clinical presentation. And pagka sobrang dami, pwede kang magkaroon ng airway obstruction. And these papillomas can be traumatized and bleed. They can bleed and you can present with hemoptysis. They can recur, but remember that these are benign lesions, no? So they're not capable of malignant transformation. Now, your malignancy ng larynx, no, your laryngeal carcinomas, it's a disease of the elderly, no, and these are your risk factors: smoking, alcohol, HPV, no, even asbestos and head and neck radiation. Okay, so the most common histology is your squamous cell carcinomas. You can see here in the photograph. So keratinizing ito, meron ka ding mga keratin pearl, no. So again, hoarseness, no, yung clinical presentation. Kaya nga wino-work up yung mga hoarseness patients kasi to rule out cancer. Now, for your ear, isa lang i-discuss ko, otitis media lang. It's common in your children kasi usually pag nagkaroon sila ng respiratory tract infections, yun, nagkakaroon din sila ng fluid build-up in your middle ear, no? And the chronic complication of your otitis media is a condition called your cholesteatoma. So, nagkakaroon ka ng cystic lesion, no, lined by squamous epithelium, and then you have keratinous debris, no. you have your keratinous debris here. Now that, if you have persistent otitis media, remember that your ear is in close proximity to your brain, and local extension of that infection can lead to brain abscess. Okay? Now for neck, we have two cysts na i-discuss ko, yung branchial cleft cyst. So it's a remnant of your second branchial arch, and the clinical presentation is a lateral neck mass, no? Along the length of the SCM. So it's benign. If you look at this, it's a true cyst, so may lining siya. Pwedeng respiratory epithelium, pwedeng squamous epithelium, but you have a lymphoid tissue in your stroma. So here. Yan. Yung thyroglossal duct cyst naman natin, it's a remnant of the thyroglossal duct, no? So it's a cyst din, no? It's a true cyst, so may lining din siya. Pwedeng squamous, pwede ring respiratory. But instead of lymphoid tissue, dun sa wall, ang nakikita mo ay thyroid tissue. Now, it's generally benign, no? But there are rare instances of malignant transformation, probably dun sa thyroid tissue. Okay? Now, for your paraganglioma naman, ayan, it's common in people in high altitudes and cyanotic heart diseases. Okay? So, anong itsura ng paraganglioma? It's the cell balance pattern. So, para siyang clusters of your tumor cells. So, yung naka-cluster na yun yung chief cell as pointed by your larger arrow. And then, they're surrounded by your sustentacular cells. Okay? So, yun yung characteristic appearance of your paraganglioma. You will also encounter this in your pheochromocytoma, which is basically a paraganglioma that arises in the adrenal. No? Now, for your salivary glands, your xerostomia, na-discuss naman natin yan in Sjogren syndrome. No? So, that's an autoimmune cause of it. And then, drugs, usually ang cause ng xerostomia. Especially your anticholinergics, your antihistamines, di ba nakakatuyo talaga yan. So, alam nyo na, pagka wala kang saliva, you're prone to developing secondary changes like your ulcerations and fissuring kasi you need the lubrication of your saliva. Okay? Mucocele. So, basically, ang nangyari sa mucocele, if you have a rupture of a salivary gland duct, then lalabas dun yung saliva and then magkakaroon ka ng inflammation and then mawo-wall off yon by a fibrous tissue. So, that is your mucocele. It's the most common inflammatory salivary gland lesion. Now, your ranula is also a type of mucocele, but it's a true cyst. So, may lining talaga siya. May lining epithelium siya. And a ranula is exclusive. It's a term exclusive when your sublingual duct is damaged. No? Kapag may sublingual duct involvement, ranula ang tawag. So, sialadenitis, skip ko na yan. Now, let's go to your salivary gland tumor. So, your pleomorphic adenoma is your most common salivary gland tumor. It most commonly arises in the parotid gland. So, this is a benign mixed tumor. So, ibig sabihin, meron kang proliferation of your epithelium and your stroma. So, yung epithelium niya can be your ductal epithelial or your myoepithelial cells in different configuration. So, useless nang alalahanin kung ano-ano yun. Basta different, no? Basta ang importante, benign yung epithelium. Benign yung epithelial cells. And then, they're laid out in a chondromyxoid stroma. So, parang ma-violet na parang masipon, no? Na chondromyxoid stroma. Pointed by your asterisk here. Okay? Now, this is benign, but some can have malignant transformation and you call that your carcinoma X pleomorphic adenoma. Now, next is your Wharton tumor. It's the second most common salivary gland tumor. Remember that it is characteristically associated with smoking and it almost always arises in the parotid. Okay? So, yung old name nito is your papillary cyst adenoma lymphomatosum. So, basically, you have a double layer. Yung epithelium mo ay double layer ng oncocytic cells. So, yung oncocytic cells, ang ibig sabihin nun, mas marami kang pink na cytoplasm and you have a bit of a nuclear atypia, bit lang, no? Okay? So, yun yung oncocytic change. And then, double layer yon, no? Characteristically. And then, it covers a lymphoid stroma, like that. So, it's a benign tumor. Now, your mucoepidermoid carcinoma naman, it's the most common primary malignant salivary gland tumor. It most commonly arises in the parotid, no, and then next in the minor glands. Kasi usually yung mga tumors na nag-arise sa minor salivary glands, usually malignant yun. Okay? Yung mga tumors na usually nag-a-arise sa parotid, usually benign yun. Okay? So, ang mucoepidermoid carcinoma, mucoepidermoid. So, meron kang variable mixture ng mucoid cells, epidermoid cells, or yung mukhang squamoid cells. And then your intermediate cells na mga small cells with, ang tag doon, compact cytoplasm. Okay? So, grade is an important prognostic factor. So, pag high-grade mucoepidermoid carcinoma, mas marami kang squamoid cells. So, mukha na siyang squamous CA, parang ganon. So, pag ganon na, that's high-grade mucoep and pangit ang prognosis niya. Okay? And then last is your adenoid cystic carcinoma. So it usually arises in the minor glands. So in terms of architecture, the most common is your cribriform or your parang cookie cutter appearance, and the cytology is deceptively bland. So parang small cells, uniform looking, no? Small cells uniform looking naman. So deceptively bland. But if you look at the other areas, they typically invade neurons, no? So meron kang perineural nerves. So meron kang perineural invasion. So this type of cancer, your ADCC, is aggressive, no? It's aggressive. Okay? And that ends your head and neck. Okay, so let's now go to gastrointestinal tract. Starting with congenital anomalies, meron tayong typhoid esophageal atresia. So, embryologically, isang tube lang talaga yan muna, no? Yung trachea at esophagus, and then nagkakaroon ka ng tracheoesophageal septum, tapos nagsiseparate siya to trachea anteriorly and esophagus posteriorly. Now, pag nagkaroon ka ng problem doon, pwede ka magkaroon ng typhoid esophageal atresia. So, the most common type is your type C, yan yung nasa gitna. So, ang isa pang tawag dyan, H apostrophe. No, kasi mukha kang may H and then may apostrophe. Kasi yung apostrophe, siya yung proximal esophageal atresia and then distal esophageal, tracheoesophageal fistula. Okay, so if you look at the clinical manifestations, you have aspiration because syempre, meron kang connection between your airways and your GIT, no? You have suffocation, pneumonia, and severe fluid and electrolyte imbalances. For duodenal atresia naman, no, hindi siya magka-connect, no, yung stomach at yung duodenum. Kaya meron kang discontinuity and you will present with obstruction. Now, ano ba nangyayari dito? Meron kang maternal polyhydramnios kasi yung fetus, no, intrauterinely, nilulunok niya yung amniotic fluid. So, kung meron siyang duodenal atresia, meron kang obstruction doon. So, di siya makakalunok ng amniotic fluid and then may ipon yon doon sa uterus kaya tumataas yung amniotic fluid index ni mommy, no? Tapos vomiting, no, depende kung nasa ang level of obstruction ka. Okay? And sa imaging, meron kang double bubble sign. So ito yon yung nasa picture, tignan nyo. Yung isang bubble yung stomach, yung isang bubble yung duodenum. Now, bakit bilious or non-bilious? Yun nga, depende kung nasa ang level ka ng duodenum yung obstruction. If it's before ma-encounter yung bile, no? So before the ampulla of Vater, kung saan nagde-drain yung no? Kung saan nagde-drain yung common bile duct. Kung before that, edi ibig sabihin, wala kang contact with bile, so non-bilious. But after that, kung after pa that yung obstruction mo, then meron kang contact with the bile, so pwedeng bilious. Okay? So imperforate anus, ano na yan? Self-explanatory. Diaphragmatic hernia. So, pag meron kang diaphragmatic hernia, yung abdominal organs mo, herniate yan papunta sa thoracic cavity. Now, syempre, it will cause pressure atrophy, no, on the developing lungs, kaya magkakaroon ka ng pulmonary hypoplasia, no? So, meron kang two types here, Bok-Dalek and your Morgagni. So, paano ko siya tinatandaan? It's back the left, no? So, it's a posterolateral defect na left-sided for your Bok-Dalek. And then, kabaliktaran yung Morgagni. Now, for omphalocele and gastroschisis, embryologically, lumalabas yung ating viscera, no? So, meron kang physiologic herniation which happens at 6 to 10 weeks AOG. Then, babalik naman yan, no? Well, pag di siya bumalik, edi yon. Doon ka pwedeng magkaroon ng either omphalocele or gastroschisis. So, pag omphalocele, nakasak siya. Pag gastroschisis, hindi. So, wala siyang sac. Okay? And you have a transmural abdominal wall defect. For ectopia naman and heterotopia, so pinag-aralan natin to sa chapter 6, so meron kang ectopic tissue somewhere else, no? So, depende na lang kung ano yung ectopic tissue at kung nasaan siya, dun magva-vary yung clinical features. For example, here, no, you have an esophagus and then meron kang ectopic gastric tissue doon, no? And that's what you call your inlet patch. So, pwede ka magkaroon ng Barrett esophagus, no? Pwede ka magkaroon ng esophagitis kasi nga may acid kang pinoproduce, no? So, and so on. Okay? So, for meccal diverticulum, it's the most common true diverticulum and congenital anomaly of the GI tract. So, actually, may rule of 2 sa Meckel's diverticulum. So, lahat ng naka-underline, yun yung kanyang rule of 2. 2% of population, twice common in males. It occurs within 2 feet from the ileocecal valve. Approximately 2 inches yung length, and most become symptomatic before 2 years old, no? So, ang problem here is the failure of the vitelline or the omphalomesenteric duct involution. So, nagkakaroon ka ng meccal diverticulum. This is a true diverticulum, meaning there are 3 layers of the intestine here. So, you see your mucosa, your submucosa, and your muscularis, no? So, ang lining niya, syempre, parang small intestine din kasi nga andun siya sa ileum usually, and you can have ectopic pancreatic or gastric tissues. So, depende kung ano yun nandun, no? Pwede ka magkaroon ng bleeding, no? Yan. And obstruction kung nagkaroon ng fibrosis there after ng bleeding or after ng ulceration, no? Tapos, pwede ka magkaroon ng pain. So, ang differential dyan ay acute appendicitis. Okay? Now, congenital hypertrophic pyloric stenosis. So, it's more common in males and it's associated with your Turner, Edward, and macrolide exposure during the first 2 weeks of life. So, syempre, hypertrophic pyloric stenosis, yung muscle mo dun sa may pylorus ay thickened, no? Kaya nagkakaroon ka ng narrow pyloric opening, no? So, yan yung nagkakos ng obstruction. Now, you can have non-bilious vomiting there kasi nga before nung ampulla, no, before siya magkaroon ng contact with the bile, yung obstruction. Kaya di siya in contact with the bile, so non-bilious yung vomiting mo. And you can also have an olive-shaped abdominal mass. Now, the treatment is myotomy. Now, we have your Hirschsprung disease. So, anong nangyayari sa Hirschsprung? Meron tayong mga myenteric and submucosal plexuses, no, normally, and then sa Hirschsprung, nawawala sila. Okay? So, it's linked to some mutations, no, like your RET mutations. And ang nangyayari, nagmamigrate kasi yung mga neural crest cells, no, cephalocaudally. So, kung di sila nakaka-migrate, no, or namamatay sila prematurely, then ang nangyayari, hindi sila nakakarating doon sa distal segments ng colon, no? Kaya the rectum is always affected. Now, anong effect nun? Yung ganglionic segment will be constricted, no? Will be constricted, and then yung normal segment, syempre maiipunan yon ng intestinal contents. So, siya yung magdadilate. So, yung distal na constricted, yun yung may problem. Yung proximal na dilated, yun yung normal. Okay? So, if you look at this under the microscope, dun sa may constricted segment, wala kang makikitang ganglion cells, no? In your yung mga ganglion cells in between sila meron ka sa submucosa, yun yung Meissner, and then meron ka sa gitna nung dalawang muscularis layers, yun yung Auerbach. Okay? So, yun. Well, because you have distension, no? You have distension, bowel edema, and all that, no? Pwede kang magkaroon ng infections, fluid and electrolyte imbalance, and syempre may dilated colon ka. It's prone to rupture. Kapag nag-rupture yan, pwede kang magkaroon ng peritonitis. Now, clinically, itong mga patients ito, yung classical history nila, they have failure to pass meconium, and then you have an explosive passage of your feces once it's facilitated, no? Yung pag-poop nung baby. Okay? For esophagus naman, let's talk about esophageal obstruction. So, syempre, pag may obstruction sa esophagus, di ka makalunok ng maayos, no? You will have difficulty swallowing. Now, there are diseases na called functional obstruction, no? Pag sinabing functional, wala kang anatomic obstruction, wala talagang nakaharang doon. It's more of a motility disorder. There is something wrong with the normal motility of your esophagus. Kaya ka nagkakaroon ng obstruction. So ito yung mga examples, no your nutcracker, diffuse esophageal spasm, LES dysfunction. So because of the increased pressure na nagbi-build up dun sa esophagus, pwede ka magkaroon ng mga diverticula, no? And these are the different diverticulas with different clinical manifestations depending on kung nasaan siya. Okay? Now, for anatomic obstruction, syempre, alam mo nyo na, meron talagang organic cause. Yan, no? Stenosis, ibig sabihin, narrowed lumen. So, ano-anong pwede mag-cause nun? Reflux, radiation because of fibrosis, caustic injury because after ng caustic injury, magkakaroon ka ng fibrosis. Or, more ominously, you have your CAs. No? Now, mucosal webs and rings, ang webs ay semicircumferential, ang rings ay circumferential. No? Now, sa webs, take note that they're associated with your Plummer-Vinson syndrome, no? Together with your iron deficiency anemia, glossitis, and cheilitis. Now, for your achalasia, ang nangyayari naman dito, nawawalan ka ng nitric oxide producing neurons. Now, why is this important? Because your nitric oxide, it facilitates peristalsis, no, and LES relaxation. So, pag wala ka ng nitric oxide, that will cause the characteristic abnormalities of your achalasia. So, your LES won't be able to relax, your LES will have an increased tone, and you will have a peristalsis. Now, these are the causes, no? Notable dyan ay yung Trypanosoma cruzi or yung Chagas disease. And then, meron kang other diseases, no? Na nagkakos ng achalasia. Okay, so they will it will present with dysphagia, no, difficulty in belching and chest pain, and treatment is myotomy. So kapag nag-barium studies ka in a patient with achalasia, since hindi nakaka-relax yung lower esophageal sphincter mo, ang nangyayari narrowed yon. And then magdadilate yung proximal esophagus mo, no, proximal to the diseased segment. So nagkakaroon ng bird beak sign, and the beak corresponds to the incompletely relaxed lower esophageal sphincter. Okay? Now, reflux esophagitis. So, alam nyo naman, ang trigger nito ay yung GERD. Okay? And these are the following risk factors. So, bakit ka nga ba nagkakaroon ng reflux? No? You have your transient lower esophageal sphincter relaxation. So, na-expose yung distal esophagus dun sa gastric contents, and you will have inflammation, hence reflux esophagitis. So, there are eosinophils in your squamous mucosa together with your thickening of your basal zone, layer. Okay? So, alam nyo naman ang heartburn for sure. Maraming meron sa atin yan, no? And the complication of this is your Barrett esophagus. So, ano ba yung Barrett esophagus? We have already discussed this since chapter 1, no? As early as chapter 1, your metaplasia. It's an intestinal metaplasia within the esophageal epithelium. So, you see your goblet cells, and pwede kang magkaroon dito ng dysplastic changes, and that is more ominous kasi yun yung mukhang magpo-progress to CA. Okay? Now, Mallory-Weiss tear naman sa lacerations, ito yung mga longitudinal tears in your GEJ associated with your retching, no? And there is a problem with the synchronization of your relaxation and your contractile antiperistaltic contractile wave. Kaya ang ending, nagkakaroon ng wall stress and nagkakaroon ng laceration dun sa GEJ. So, syempre, kung may laceration, may pagdudugo. Kaya sila yung hematemesis after ng retching. Okay? Now, Boerhaave is rupture, no? Transmural rupture and tearing of your distal esophagus, and therefore, pwede kang magkaroon ng mediastinitis. Okay? And you can have severe chest pain and shock, which is a mimic of your MI. So, esophageal varices naman, pag may portal hypertension ka, mag-open, if you have cirrhosis, for example, no, you will have portal hypertension. Discuss natin yan mamaya sa liver. So, because of the portal hypertension, your portocaval anastomosis will open. And in the esophagus, it's between the left esophageal branch of the left gastric vein and your azygos vein, no? Now, magkakaroon ka ng dilation ng submucosal vessels mo doon, and yun yung esophageal varices. Kaya nakakatakot for your liver failure patients, no, those with chronic liver disease, kasi ito yung pwede nilang ikamatay, no, yung excessive variceal bleeding. Okay? So for esophageal carcinoma, okay, yung of course, syempre dahil may obstruction ka, you will present with dysphagia, a painful pain during swallowing, no, and if it's a bleeding tumor, you can have hematemesis then, no, and of course you will have weight loss, no, as we have discussed in your chapter 6. Now additionally, if you have adenocarcinoma, usually may history ka ng GERD, no, kasi yun yung nasa may distal part. Okay? Now, esophageal carcinoma is one cancer that you don't wanna get, no? Kasi usually when you catch them, advanced na. Okay? Bakit? Because the anatomy of the esophagus, it facilitates the spread of the tumor. Actually, Teka, mali ito, no? Dapat negative serosa, no? Walang serosal layer ang esophagus. Okay? Please take note, walang serosal layer ang esophagus. That's a correction. And then you have increased lymphatics. Okay? Nakapalibot yan across dun sa throughout, along the length of the esophagus. Na wala siyang serosa, no? Kasi yung serosa, yan yung layer ng peritoneum na pumipigil, no? Dun sa yan parang isang barrier yan. Okay? So pag walang serosa, mas mabilis spread yung tumor. So prognostic factors, of course, staging, and the staging consists of, like in a lot of GIT disorders, no, your depth of invasion is the T, and then your N nodal, and then M distant metastasis. Okay. Now, the two main types, you have your squamous cell carcinoma, usually happens in the middle third, no? Kasi squamous epithelium yung nandun. Iba yung set of risk factors ng squamous cells sa adenocarcinoma. Sa squamous cell, smoking, alcohol, radiation, you know the usual, na parang nakikita nyo sa head and neck din, no? Or sa oral cavity in particular, no? And then, meron pang ibang additional, no? Hot drinks, HPV din, di ba? Like in your head and neck din. Caustic injury, because after that, magkakaroon ka ng inflammation, no? And chronic inflammation, fibrosis, no? So, pagka ganun, pwede ka rin mag-develop ng cancer. Okay? And Plummer-Vinson syndrome and achalasia as well. And then, for adenocarcinoma naman, ang set of risk factors niya, GERD, no? Smoking and radiation is shared, no, ng squamous cell and ng adenocarcinoma. Okay? Atrophic gastritis is protective. Bakit? Kasi decrease ang gastric acid output mo, no? Kaya hindi ka masyadong kaya siya protective. Okay? So it's in the distal third. So let's go to the stomach naman. So let's talk about gastritis and gastropathy. So basically, sa stomach, meron tayong protective factors, no, which include your mucus, bicarbonate, mucosal blood flow, etc., no? And then meron tayong injurious factors, no, like your H. pylori, NSAIDs, tobacco, alcohol, gastric acid, no, etc. Okay? Now, ang nangyayari is, in gastritis or gastropathy, you have an imbalance between your injurious factors and your protective factors, such that mas marami yung injurious factors, no? Kaya, nagkakaroon ka ng mucosal injury. Okay? So, syempre, pag gastritis, masakit, epigastric pain, no? They can also have nausea and vomiting. So, example, if you have an NSAID-induced gastritis or gastropathy, no, your NSAIDs, no, you decrease the synthesis of your vasodilatory prostaglandins or your cytoprotective prostaglandins. Okay? And that means you decrease, no, your protective factors. Kaya ka nagkakaroon ng peptic ulcer, 'di ba? Parang ganon, no? So, laging ganun lang naman yung tatandaan nyo. Here in your stress-related mucosal disease, no? So, itong mga to, yung shock, sepsis, trauma, syempre, mababa ang mucosal blood flow mo niyan, di ba? Kaya pangit. Okay? Now, for burns, syempre, mababa din ang mucosal blood flow mo because in burns, di ba, you lose, no, mababa ang intravascular volume mo because you have leaky capillaries because they're destroyed, no? Now, for increased intracranial pressure naman, because of direct vagal stimulation, you increase your gastric acid. So, you increase your injurious factor. So, ganun, di ba? Basically, yun yung basic pathogenesis niya. There's an imbalance between the protective factors and the injurious factors favoring the injurious factors. Okay? So, yun. Ang stress-related mucosal disease, multiple siya, no? Multiple ulcers, no? Kasi yung peptic ulcer, isa lang. Okay? Gulifoil lesion. So, ang Gulifoil lesion, you have an abnormal submucosal arteriole and then parang thin lang yung thin yung mucosa niya. Now, pagka nagkaroon ka ng ulceration dun sa mucosa na yon, of course, matatrauma mo yung vessel kaya magkakaroon ka ng bleeding. No? Yun lang naman siya. Now, of course, Helicobacter pylori gastritis. So, it's the most common cause of your chronic gastritis. And these are the associations, no? Poverty, low socioeconomic status, as if low SES isn't, enough, no? Sinama pa yung poverty and rural residents. Actually, may running joke kami dito. Pag may H. pylori gastritis ka, biopsy proven poor. Charot. Okay? So, anyway, etiology of this is your H. pylori, no? It's parang helical yung niya, kaya nga Helicobacter. Okay? So, meron siyang mga ganitong virulence factors. So, flagella for motility, urease, no? So, yung urea, yung urea, binibreakdown ng H. pylori because of its urease into ammonia and CO2. Now, your ammonia increases your gastric pH, which allows H. pylori to thrive. They also have adhesins para maka-adhere sila, no, sa foveolar epithelial cells. And CAG is the most important because it's the one associated with your atrophic gastritis and therefore associated with gastric cancer. Okay? So, basically, ang nangyayari when you have H. pylori gastritis, it induces inflammation, no? When induces its inflammation, syempre, magkakaroon ka ng tissue damage, no? So, that will cause a bit of mucosal atrophy. So, mababawasan yung glands mo doon, no, sa mucosa mo. And that will cause a decrease in your gastric acid output, no? Kasi syempre, acid-producing yung mucosa ng stomach. So, pag na-destroy yun, medyo magdi-decrease yan. Now, the reflexes for gastrin, no, to be produced in order to push, no, your gastric acid output, your gastric acid to be produced, no? Kaya, pwede kang low kung hindi niya ma-compensate, no, yung production, or pwedeng normal gastric acid if compensated. So, of course, lab features, you have antibodies to H. pylori. Of course, you have organisms on your biopsy pag tinignan mo. And pwede kang kumuha ng bite ng mucosa and then i-subject mo to rapid urease test and magpa-positive yon. Now, yung isa naman, yung autoimmune, syempre pag autoimmune diseases, no, usually may kasama yung ibang autoimmune disease. So, yun yung usually niyang associations. And of course, autoimmune destruction of parietal cells. Okay, your parietal cells are the acid-producing cells of your stomach, no? Okay? So, ang nangyayari because you have an autoimmune attack against your parietal cells, you will have a markedly decreased gastric acid, no? If you have markedly decreased gastric acid, then you will have markedly increased gastrin, no? Kasi yung gastrin, syempre napoproduce siya kapag bumababa yung gastric acid output mo. Kasi kailangan mag-produce ka ng gastric acid, okay? But makaka-recover ba yung stomach? Hindi. Kasi you have diffuse destruction of your parietal cells. Wala nang magre-respond dun sa gastrin. Okay? Also, your also your parietal cells, no, nagpo-produce sila ng intrinsic factor. So, pagka ganun, magdi-decrease din yung intrinsic factor mo, which will result in your low vitamin B12 absorption kasi kailangan mo yun for its absorption. So, you will have megaloblastic anemia, and that's what you call your pernicious anemia. So, we have already discussed that in chapter 13, no, in your RBC, in your one of your hypoproliferative anemias. So, basically, if you have this condition, you will have pernicious anemia, you will have B12 deficiency, no, together with other symptoms of B12 deficiency like your atrophic glossitis and etc. So, ang tatandaan nyo lang sa morphology ng sa differences in morphology ng H. pylori and your autoimmune, usually your H. pylori sa antrum yan nagsisimula, while for autoimmune the antrum is paired, no? Usually it affects the body and fundus. And in H. pylori, you have patchy or multifocal atrophic gastritis. While in autoimmune, since lahat may antigens, no? Lahat ng parietal cell dun sa stomach mo ay may antigen. Lahat yun inaatake ng katawan. Kaya diffuse ang mucosal atrophy in your autoimmune gastritis. Okay? Malinaw? Okay. So, for your peptic ulcer disease naman, yan, ano bang meron dito, okay? So, anyway, ang etiology ng ating peptic ulcer disease, no, H. pylori nangunguna, and then NSAIDs and cigarette smoking, no? So, yung H. pylori kasi, yung H. pylori mukhang very common yan siya. Mukhang parang siya ang pinaka-common sa lahat. It causes 70 to 90% of your gastric ulcers and 90% of your duodenal ulcers. Now, there are other causes of your peptic ulcer disease aside from this holy trinity, no, of things. Yung GI, yung ectopic gastric tissue mo, 'di ba, yung inlet patch and all that, no? And then if you have a Zollinger-Ellison syndrome, di-discuss natin yan later on in your endocrine. But anyway, it's a gastrin-producing pancreatic neuroendocrine tumor. So if you have increased gastrin production, you will have increased gastric acid secretion, and therefore you will have peptic ulceration, no? Kasi because of increased gastric acid. So basically, ang problem with your peptic ulcer disease is that you have too much acid and it destroys your mucosa, no? So for H. pylori, you have inflammation, no? And syempre, if you have inflammation, you have a bit of a patch mucosal atrophy, no? Kaya bumababa ng konti yung gastric acid mo, and then that can trigger your gastrin, no, to be produced, and then nagkakaroon ka ng increased gastric acid. Now, also, H. pylori infection, it causes decreased duodenal bicarbonate secretion. So, basically, wala kang base, no? Kaya, pa-acidic yung magiging pH ng duodenum mo, and therefore, pwede ka magkaroon ng ulceration. Ganon. Okay? So, ang tatandaan nyo, ang itsura ng peptic ulcer na benign, no? Kasi may mga malignant din na ulcers eh. Ang itsura ng benign peptic ulcer, dapat siya ay very sharply circumscribed, no? Very sharp yung borders niya, kitang-kita mo talaga. And then, leveled lang, ka-level lang ng mucosa yung edges niya. Pag yan may heaped up borders, naku, matakot ka kasi baka malignant ulcer yan. Okay? So, in terms of morphology, well, diniscuss natin yan sa chapter 2, di ba? It's one pattern of your acute inflammation, no, yung ulcer. So, NIGS, you have necrosis, inflammation, granulation tissue, and fibrosis. Okay? So, yun. From superficial to deep. Okay? So, peptic ulcer, alam na siguro natin ang clinical presentation. You have burning epigastric pain, no, after meals. And in patients with duodenal ulcers, no, pwede ka magkaroon ng nocturnal awakening. Now, of course, in patients with peptic ulcer, usually the pain is usually relieved by food or an antacid. Okay? So, syempre, you have mucosal ulceration. If it happens to involve a vessel, you can have a bleeding peptic ulcer. If it's too deep, then you can have perforation, no? And, of course, may hangin yung laman. You can have pneumoperitoneum, no? And then you can have obstruction. Kapag nag-heal kasi yung ulcer by fibrosis, pwede ka magkaroon ng stricture. Okay? Now, let's go to your polyps and your tumors in your stomach. So, pag inflammatory or hyperplastic polyps, usually associated with your H. pylori infection. No, it's the most common gastric polyp. Ang nangyayari lang dito, nagre-react lang kasi yung mucosa mo to your H. pylori infection. Kaya parang nagkakaroon ka ng reactive hyperplasia that can turn into a polypoid mass. Okay? Now, yung fundic gland polyp naman, it can be associated with your familial adenomatous polyposis kasi if you look at that, yung adenomatous polyposis coli gene, no, yung APC gene, yan din yung associated sa FAP, no? Kaya connected siya sa fundic gland polyps. Or, sporadically, you can have a proton pump inhibitor use. Ang nangyari kasi dyan, when you have PPI use, you increase your gastric pH, no? And if you have decreased gastric acid output, then tinitrigger ng katawan na mag-produce ng gastrin to produce your acids. So, syempre, yung gastrin, it increases your acid secretion by producing parietal cell hyperplasia. No, and some of them nagiging cystically dilated. Kaya basically ang laman niya ay oxyntic mucosa or acid-producing mucosa with cystically dilated glands. Yeah. Okay, gastric adenoma. So these are the associations, no? Associated din siya with your familial adenomatous polyposis, and that's the reason why pwede ka ring magkaroon ng extracolonic polyps, no? Kapag meron kang familial adenomatous polyposis, hindi lang sa colon. Kay H. pylori and autoimmune gastritis, so alam nyo na yung H. pylori at yung autoimmune gastritis ay risk factors for CA, no? Kasi itong adenomatous polyps ng stomach, yan yung mga precursors ng CA. Okay? So basically, may dysplasia ka na dun sa glands, no? Pero wala pang invasion. Now, in terms of prognosis, size is predictive. So, if you have more than 2 cm na gastric adenoma, there's a high risk of malignant transformation there. Now, gastric adenocarcinoma is the most common gastric malignancy, and if you look at the risk factors, you have your H. pylori, atrophic gastritis, so ibig sabihin, pwede ring autoimmune gastritis, no? Anything that can cause atrophic gastritis, no, can be a risk factor for gastric CA. And then meron tayong iba pa, no? Smoking, radiation, asbestos, Epstein-Barr, lead, nitrates, and processed meat. Okay, so kasi may dalawang types ng CAs, no? Your intestinal and your diffuse infiltrative. But that is lumang classification na yon. Pero para convenient lang, ganun ko siya na-discuss. Okay? So there are different pathogenetic mechanisms depending on the type. Okay? Yun na lang. Most common site is your antrum, and they can be exophytic masses or infiltrative, no? Or infiltrative ulcerating masses. Kaya sinasabi ko sa inyo, importante na alam nyo ang morphology ng benign ulcer sa malignant ulcer. So again, pag benign ulcer, smooth yung edges and then level lang yung mucosa, yung edges sa mucosa. Pagka malignant ulcer, usually heap up yung borders. Okay? Or if you have a diffuse infiltrative, no, type of gastric CA, you can have a thickened gastric wall, no, and the stomach becomes non-distensible, no, and that's what you call your linitis plastica. So pag sinabing adenocarcinoma, yun naman yung glands, no, you see here malignant glands infiltrating your gastric wall. So, pwede ka magkaroon ng tubular or papillary patterns, no? Pwede ka rin magkaroon ng signet ring cells like this. Okay? So, yun. So, basically, ang presentation ng gastric CA is vomiting, 'di ba? Early satiety, especially if hindi distensible ang stomach mo, no? And prognosis, of course, stage pa rin ang pinakamahalaga. And like your other GIT cancers, yung T category niya is the depth of invasion, kung gaano kalalim. Now, lymphoma. Okay, so the lymphoma, the most common type is your mouth lymphoma. We've already discussed this in chapter 12, no? So your marginal zone lymphomas, diba, they arise in tissues with chronic inflammation. And in the context of gastric lymphoma, you have your H. pylori infection, no? And like I said in your chapter 13, No, your H. pylori causes chronic inflammation, so siya yung trigger, no? And then from then on, dun magkakaroon ka ng antigen-dependent lymphoid proliferation, no? And that constitutes your lymphoma. Now, somewhere along the way, they can gain chromosomal abnormalities, which makes their growth independent of your H. pylori infection, and therefore they can hindi mo na pag in-eradicate mo yung H. pylori, hindi na rin siya helpful. So dapat early on ini-eradicate agad ang H. pylori, okay? So like I said, ang mga lymphomas medyo walang kwentang magsaulo ng morphology. They're just small lymphoid cells that infiltrate your stomach. Basically ganun lang, no? So ini-immunostain lang talaga yung mga yan, so don't bother, no? Sa morphology ng lymphomas. Anyway, it's indolent nga. But remember, as with any other indolent lymphomas, they can transform into DLBCL. Okay? So, neuroendocrine neoplasms, remember your bronchial carcinoid, parang siya yung pulmonary analog ng mga GIT neuroendocrine neoplasms. Okay? So, the most common site of your neuroendocrine neoplasms is your GIT, particularly in your small intestine. And if you know your morphology of your bronchial or your pulmonary carcinoids, then ganun din naman yung morphology ng mga nets in your GIT. So, they can present with mass, obstruction because of strictures, no? Pwede ka magkaroon ng strictures. And these are neuroendocrine neoplasms, so they're capable of producing bioactive substances that can cause your carcinoid syndrome. More of that later on, siguro sa endocrine na lang. No, anyway, your neuroendocrine neoplasms, ang prognostic factors niyan, yan, grade, mitosis, or location, no? And location. So, pangit ang mga mid-gut nets. So, those that are located in your jejunum and your ileum, pangit ang prognosis nila. For your GIST naman, it's the most common abdominal mesenchymal tumor, and please remember the associated diseases, your NF1, Carney triad, no, which includes your GIST, paraganglioma, and your pulmonary chondroma. So it's thought to be derived from your interstitial cells of Cajal, and the cause is your KIT and your PDGFRA mutation. So, KIT yung mas common, no? Now, in terms of morphology, can be spindle, can look like epithelial or epithelioid or mixed, no? And IHC, you need IHC for the diagnosis of this. Kasi they can look like anything. So, ang ginagamit namin is KIT, no? CD117, or a more specific one, it's your discovered on GIST 1 or DOG1. Well, nice to know naman usually yung IHC for the most part, but it pays for you to know this. Okay? So anyway, ang growth kasi nila, ang growth nila usually palabas, no? So, pag malaki yung mga tumor na yon, they can cause compression of your intestines from the outside. So, yun yung tinatawag na extrinsic bowel obstruction. Now, they can also go inward and then compromise your mucosa. So, pwede ka magkaroon ng bleeding. So, in terms of prognosis, it depends on the size, the grade, and the site. Now, the magic number for this is 5. If it's more than 5 or more than 5 mitosis, no, more than 5 mitosis for 5 square millimeter, or if it occurs outside the stomach, no, pangit ang prognosis ng GIST. Okay? So, here we have an example of a high-grade GIST kasi ang dami mong nakikitang mitosis, no, agad-agad. Okay? So, grade ang deciding factor ng mitosis, ang deciding factor ng grade in your GIST. Now, let's go to your intestinal obstruction. So, here we have the 4 forms of your intestinal obstruction. So, hernia is the most common overall, and in children less than 2 years old, it's intussusception. Okay, so these are the following definitions that's self-explanatory. But remember that when you have an intussusception in adults, think tumor, no? So, may tumor yan. Sometimes benign, like a lipoma, no? But, of course, pag minamalas yung pasyente, CA yung nandun. Okay? Now, ischemic bowel disease, well, diniscuss na rin naman natin yan in hemodynamic disorders. Okay? So, actually, hindi na ako masyadong magdedwell dyan. But of course, the clinical picture of your ischemic bowel disease, you know that it suffers from hemorrhagic infarction because meron yung collateral circulation, it's a hollow organ, no? It's a loose organ. Therefore, you can have bleeding. No? Therefore, you can have bleeding. And when you have bleeding, maraming fibrin doon, and your fibrin will trigger fibrosis. So basically, itong mga bowel infarction na to, nag-heal to by fibrosis. And if malas-malas ka, pwede yung maging stricture. Okay? Now, in acute cases, of course, if you have a lot of bleeding, then you can go into shock. No? And that infarcted bowel segment will be weak. So, pwede ka ring mag-perforate. Okay, so here in the picture, naka-highlight yung necrotic part ng bowel. Now, for infectious enterocolitis, ipapaubaya ko na sa inyo yan. But, meron tayong mga trends, no? So, kapag toxin, no, like in your enterotoxigenic E. coli, no, usually, walang bloody diarrhea. So, for here, it's watery diarrhea. Okay? Exception, tapos, kapag invasive yung organism, syempre kapag nag-invade yung organism sa ating mucosa, ang magkakaroon niya ng inflammation, magkakaroon niya ng tissue damage, kaya nagkakaroon ka ng bloody diarrhea. Now, an exception to that is your Shiga toxin-producing E. coli or your O157H7, which you have encountered in your chapter 13, no, in your thrombotic microangiopathies, in your hemolytic uremic syndrome. You have learned that your Shiga toxin, it causes endothelial activation and therefore thrombosis and all that jazz. No, kaya ka nagkakaroon and tissue damage na yun. Kaya ka nagkakaroon ng bloody diarrhea. So iba yung kaniyang mechanism, no? Now, celiac disease. So, it's a malabsorptive disease. No, ang nangyayari sa kanya, nagkakaroon ka ng symptoms when you eat, no, when you take foods with gluten. Okay? Now, tandaan nyo yung mga HLA alleles associated with your celiac disease, your DQ2 and your DQ8. Okay? So, ang nangyayari, since you're kapag nagkaroon ka ng intake ng gliadin, no, basically magkakaroon ka ng intestinal damage, no? And that is in the form of mucosal atrophy, no? Villus atrophy of your small intestinal mucosa. And because you need that architecture, no, you need your mucosa to be intact for you to absorb, no, your nutrients. Kapag nagkaroon ka ng mucosal destruction in your small intestine, that will lead to malabsorption. Okay? So, yun. And also, associated siya with your dermatitis herpetiformis. This is an inflammatory blistering disease that we will discuss on the skin chapter na. Now, the treatment is you avoid gluten. You avoid gluten. And remember, may mga gluten-free starches naman tayo like your corn, arrowroot, potato, and tapioca. So, as with any autoimmune diseases, because this involves chronic inflammation, you know that these patients, they have a high risk for developing malignancy, can be a lymphoma or a small intestine carcinoma. Okay? So again, babalik pa rin tayo sa chapter 6. Nakikita nyo kung gaano kahalaga yung first 9 chapters, especially the cellular injury and death, inflammation and repair, hemodynamics, immune, neoplasia, and infectious. So, yung 6 na yon. Kasi doon tayo nabalik lagi, no? So, remember that your chronic inflammation, it's a cancer-enabling element. So, inflammatory bowel disease. Autoimmune attack din to, pero against your mucosa. So, basically, ang nangyayari, you have an insult, no, that causes chronic mucosal activation and therefore injury. Okay? So, ang tandaan nyo lang naman, meron chronic diseases ito. So, they have changes that are typical of chronic mucosal injury like the ones mentioned here, no? But your non-cacheating granulomas, tandaan nyo sa Crohn's yan. Okay? Anyway, as with any other diseases with chronic inflammation, you can have cancers, no? Kapag meron kang inflammatory bowel disease. So, in keeping with the fact that when you have chronic inflammation, it's a cancer-enabling element, no? Now, ito yung mga tatandaan nyo sa inflammatory bowel disease. Hindi ko na masyadong i-discuss, no? Kasi lagi yan tinatanong. So, andyan naman lahat na yon. So, kayo na bahala. But just remember, yung granulomas, ano yan? Yung granulomas sa Crohn's, yan. Okay? The transmural inflammation is in Crohn's. Okay? The skip lesions, Crohn's. Rectal sparing, pwedeng mangyari sa Crohn's, but your rectum is always involved in your ulcerative colitis. In terms of clinical features, no, if you have Crohn's, if you have Crohn's, sa smoking, risk factor siya for Crohn's, but for ulcerative colitis, it partially relieves symptoms. And appendectomy increases the risk for your Crohn's disease while it's protective in your ulcerative colitis. Now, let's go to your sigmoid diverticular disease. It's common in the elderly, and the risk factor is decreased dietary fiber. Ano bang nangyari dito? When you have increased dietary fiber, usually, nagkakaroon ka ng increased bowel stress kasi nga, hindi naman nakakapas ng mabilis yung iyong poo, no? So, pwedeng ang tigas-tigas nila. So, you need a lot of luminal pressure in order to expel those. So, anyway, dahil mataas yung intraluminal pressure, nag-herniate, no, yung mucosa ng sigmoid colon into areas of weakness. And these areas correspond to the sites where your vessels penetrate your wall. Okay? So, at dahil dyan, yung mucosa lang yung nag-herniate, it's a false diverticulum dahil wala siyang 3 layers, no? Sa kanya, mucosa and submucosa lang yung nakikita mo. Walang muscularis. Okay? So, usually it happens in your sigmoid nga, di ba? And therefore, pwede ka magkaroon ng, if that gets inflamed, no, pwede ka magkaroon ng pain sa left side. So, kaya tinawag siyang left-sided appendicitis. Now, if it heals, you can have strictures which can present with gut obstruction. If it perforates, you can have peritonitis. Let's go to your polyps of your intestine. So, hyperplastic polyp, benign, no? It has a serrated architecture, no, which is limited to the upper two-thirds lang, no? Upper two-thirds lang ng crypt. So, benign yan. Anyway, di na masyadong mahalaga. Mahalaga lang yung mention ko lang yung morphology kasi may i-compare lang ako sa kanya. Pero other than that, basta pag narinig yung hyperplastic polyp sa colon, benign yon. Okay? So, in contrast naman to a sessile serrated lesion, now this one has malignant potential. And pareho silang may serrated architecture. That's why you have to differentiate it from your hyperplastic polyp. Okay? So, ang ganyan naman kasi, the serration involves all the way, no? Hanggang baba, no? Ng gland. And then, pwede ka magkaroon ng dilation ng crypt and then lateral growth, no? Once it encounters the muscularis mucosa, pag ganun siya mag-growth. So, yun yung tinatawag na elephant feet glands, no? They can or cannot have, pwede silang meron or wala, no? Na dysplasia. And like I said, meron tong malignant potential. So, this is a precursor to cancer. Okay? Compared to your hyperplastic polyp which is benign pero pareho silang may serrated architecture. Kaya ko lang sinabi yung morphology. Okay? So, pag conventional colorectal adenoma, nakita niyo yung gastric adenoma, no? Parang medyo ganun din yung kanyang itsura. Okay? So, you can have tubular like on your right or villous, no? Yung finger-like na maninipis. Or a mixture of the two, your tubulovillous. You can have either low or high-grade dysplasia, and these are the poor prognostic factors. So, size pa rin ang single most important characteristic, di ba? Like in your gastric. Sa gastric, more than 2. Sa colon, more than 4. And if you have villous architecture, that's more evil. Okay? Of course, if you have the high-grade dysplasia, pangit yon. And if you have multiple lesions, pangit yon. Now, for your familial tumor syndromes. Now, the following are inherited in an autosomal dominant manner. Your FAP. No, sir, your FAP, no, your familial adenomatous polyposis. The defect is your APC, or adenomatous polyposis coli gene. So, it's a tumor suppressor gene and therefore termed to as the gatekeeper of colonic neoplasia. So, the diagnostic criteria is you have to count more than 100 colorectal adenomatous polyps. Because your APC is associated with polyps like in your stomach, no, you can also have extra colonic polyps. Okay? So, syempre, kung madami kang adenomatous polyps, madami kang chance na mag-develop ng cancer. Kaya adenocarcinoma develops in all untreated patients often before 30 and nearly always by age 50. So, yun ang dreaded sequela niya. Okay, now your Lynch naman, it's a defect in your mismatch repair. So, if you have defects in your mismatch repair, then magkakaroon ka ng DNA damage, and you know that genomic instability is a cancer-enabling element, and therefore you can have cancers in the GIT, in JUT, and in the brain or in skin. Okay? So, yun yun. Now, for your juvenile polyposis syndrome, ito naman yung defect, yung SMAD4. No? So, yung mga juvenile polyps natin, ang itsura nila ay parang inflamed, no? Na polypoid colonic mucosa with some cystically dilated glands. No? Basically, yun lang naman. And then, for your Poitz-Jeger, the defect is your STIC11 gene. And then, hamartomatous polyp ito. So, diniscuss natin yan sa chapter 6. So, pag hamartomatous polyp, hamartoma, ang nakikita mo ay yung tissues na expected mong nandun, pero disorganized. So here, meron kang intestinal tissue, you have your glands, you have your smooth muscles, no? Pero disorganized siya. So meron kang arborizing network of your smooth muscle cells. Now, part to ng Poitz-Jeger, so pag nakakita ka ng ganito, plus nakakita ka ng mucocutaneous hyperpigmentation, no? Think a Poitz-Jeger polyp. Yes, colorectal adenocarcinoma, most common malignancy of the GI tract. Remember, if you have high carbs, low fat, and low fiber diet, that's bad. No, it's a risk factor. Okay, now your NSAIDs are notably protective of your colorectal CA. Now, we also have two different pathways here. Your adenoma carcinoma sequence and your microsatellite instability. Remember your conventional colorectal adenomas, yun yung nagiging CA in your adenoma carcinoma sequence. While remember your sessile serrated lesions, those are the precursor lesions of your cancers through the microsatellite instability pathway. Well, after na, okay, ano naman tayo sa gross? So, yung, di ba may right side tayo, yung mga ascending, and then yung descending, yung left sa sigmoid. Now, pag right side, usually bulky exophytic masses yan that can bleed, no? And clinically, they will present with iron deficiency anemia because of your bleed. And you have learned in your chapter 13 that in the elderly patients, no, with an explained iron deficiency anemia, please rule out a bleeding colorectal CA. Okay? And for your left-sided naman, ito yung nagko-compress. So, nagkakaroon ka ng change in bowel habits and obstructive disorders. So, here, makikita nyo sa picture yung characteristic apple core deformity when you do your barium studies. So, yung apple core, it corresponds to the stenotic lumen because of the tumor. So, these are the morphologic patterns, no, the common morphologic patterns of your adenocarcinoma ng colon. So, have your usual, no, the tubular, no, or glandular. And then you can have a lot of tumor cells floating in your mucin pool. So, yan yung mucinous mo. And like in the stomach, you can have signet ring cells, no? Now, in terms of staging, of course, depth of invasion pa rin, no? Nodal and distant mets, the usual TNM. And of course, saan ba nagde-drain ang colon na vessels? Sa liver, sa portal system, di ba? Kaya that's the most common site of distant mets. Now, in terms of depth of invasion, yan, kung nag-invade na siya ng submucosa, that's your T1, muscularis T2, and then pag lumabas doon into the pericolorectal tissues, T3 yon. Pag nag-invade na siya ng serosa, that's your T4A. Pero pag nag-invade na siya ng adjacent structures, that's your T4B. Now, for anus, you have your hemorrhoids. So, yung hemorrhoids nyo, alam nyo yung esophageal varices nyo, parang ganun din yung pathophysiology ng hemorrhoids, no? So, therefore, magkakaroon ka ng dilated submucosal vessels. Now, you know na merong division yung anus, no? Meron siyang part na lined by glandular epithelium, no? Parang colonic. And then, meron siyang squamous na, no? So, pag squamous ang lining ng hemorrhoids, that's external. Pag intestinal, that's internal. Pag pareho nyo siyang nakikita, that's mixed. Okay? So, syempre, like your esophageal varices, bleeding din ang manifestation ng hemorrhoids. And pain usually happens in external hemorrhoids and if you have thrombosed hemorrhoids. Now, for anal tumors, the common important risk factor is your anoreceptive intercourse. Okay, so in squamous tumors, no, HPV, kaya nga anoreceptive intercourse. So parang it's because of the sexual practices. Tingnan nyo, puro HPV yung nandito. And then for the squamous tumors, and then pwede ka rin magkaroon ng adenocarcinoma. Now, if you have rectal pain, no, if you have rectal pain without any findings, normal ka lahat on workup, then that's your proctalgia fugax. Okay? Now, for appendix, of course, ang paborito nating condition, no? Common surgical condition na encounter nyo yung lagi, your acute appendicitis. So, ang nangyari in your acute appendicitis, you have your obstruction. In adults, the most common cause is your fecalith. In children, pwedeng lymphoid hyperplasia, di ba? And then because of that, anyway, nagkakaroon ka ng intraluminal pressure. Because of that, you decrease your venous drainage, and that can cause ischemia and inflammation. Okay? So, the criterion is when you have your neutrophils in your muscularis propria. So, you call that acute suppurative appendicitis. So, alam nyo na naman ang clinical ng appendicitis. And if it ruptures, you can have peritonitis. Now, for your appendiceal tumors, the most common is your Widinette, your well-diff neuroendocrine tumor. So, alam nyo na yung morphology niyan, no? So, okay na yan. And then, the most common site is the tip. Now, when you have an appendiceal Widinette, maganda naman ang prognosis niyan. And you also have your appendiceal mucinous tumors, which can be an important cause of your mucinous ascites. And in the female patient, no, aside from the ovary na pwedeng mag-produce ng mucinous ascites, ito pa yung isa nyong kailangang i-investigate na organ. Okay? Kapag may mucinous ascites ang isang babaeng patient. Okay? And that ends your GIT. Okay, so tapusin na natin yung second half ng GIT, the liver, gallbladder, and the exocrine pancreas. Okay. So let's start. Liver is quite a complicated system to tackle, no? And dahil dyan, medyo magmomorph tayo ng konti, no? Kailangan natin ng morphology ng konti just to put things in context. Anyway, so the liver responds to injury, and this are the manifestations, no? So pag reversible, think inclusions. So kung fat, steatosis, kung bile, cholestasis, and then if you have a lot of water in it, no, you will have ballooning, so you will have cell swelling, and then some clumped intermediate filaments like your Mallory hyaline. Okay? Now for irreversible, tandaan nyo cell death, no? So ano ba yung two main forms of cell death from your chapter 1? It's necrosis and your apoptosis, okay? So pag necrosis, usually ischemia and oxidative stress, but for your apoptosis, it's in viral hepatitis, no? You know, viruses, diba? And then yung acidophil body na tinatawag, kaya siya acidophil pink, no? Kaya acidophil body ang tawag. Pag sa yellow fever mo siya nakita, it's called Councilman bodies. But traditionally, ewan ko ba kung bakit na-associate siya sa viral hep. Pero dapat talaga sa yellow fever lang siya. Pero yun, acidophil body, yun yung apoptotic na hepatocyte. And then for repair, you know that in your chapter 2, the liver is a stable tissue. So, pwede yung mag-regenerate. That's number 1. And then, once the replicative capacity is exhausted, magdodoctoral reaction yan. So, the stem cells will differentiate into these duct-like structures as seen in the picture below. No? And then, syempre, pag wala ng replicative capacity, pag talagang ang sunod niyan, fibrosis na, no? And you have your vitamin A storage cells, no? They're converted into your myofibroblasts post-injury. And there are a lot of triggers, no? For that, like your reactive oxygen species, etc., mga ganon, no? And then, yung liver function tests, self-explanatory. Okay, kaya basahin nyo na lang yan. Now, let's go to your liver failure. So, pag liver failure, it's the most severe form of your liver disease which occurs at around 80 to 90% parenchymal loss. So, these are the types, no? So, let's go to acute liver failure. So, dapat, pag acute liver failure, wala kang liver disease, no? Wala kang background liver disease. And you will present with symptoms of your acute liver failure, particularly your encephalopathy and your coagulopathy. Mamaya, anuhin natin yung pathogenesis niyan. And it occurs within 26 weeks of post-insult. Maraming causes, no? Drugs, infections, no? Some metabolic diseases, no? Yun, are included in the list. Okay? So, grossly, syempre dahil maga yung liver, no, may edema, no, lalaki yung liver mo and then liliit siya because of hepatic necrosis. Okay? So, ang tatandaan nyo lang, for your liver failure, you have to remember the normal liver functions. No? So, ang liver, nag-handle yan ng bilirubin. So, pag nag-liver failure ka, you will have jaundice and cholestasis, di ba? Now, your liver detoxifies your ammonia, no? Detoxifies your ammonia. So if you have liver failure, you will have ammonia buildup in your system, and that can cause neurologic symptoms. Yun yung hepatic encephalopathy nyo. Now, your liver is also responsible for production of your coagulation factor. So pag nagka-liver failure ka, pwede ka magkaroon ng bleeding, no? Because of coagulopathy. And then you will have portal hypertension and hepatorenal syndrome. We'll discuss that later on. But if you look at your liver function test, no, pag liver failure, early on you will have increase in your liver enzymes because there's damage, no. So there's an ongoing damage and you release the cytosolic liver enzymes, okay? But for in the late phase of your liver failure, you will have decreased transaminases because wala ka ng residual normal liver, no? Viable liver. Now, for chronic liver failure, ang usual mo nakikita ay yung cirrhosis, no? So, yung cirrhosis, the liver is divided into nodules because of this fibrosis, no? And dyan, yan, nagkakaroon ka ng abnormal vascular connection. So, nagkakaroon ka ng vascular shunting. Okay? So, pareho lang naman yung symptoms ng acute and your chronic liver failure. Of course, no? Liver failure pa rin naman yan regardless. But if you notice, in your chronic liver failure, usually you have endocrine symptoms like your hypogonadism and your hyperestrogenic state. Okay? Now, portal hypertension. Siyempre, hypertension, diba? There is increased, no, pressure in the portal blood flow. So, dahil dyan, hindi maka-flow ng maayos papunta sa portal system, no, yung blood, no. There are different causes. May thunder. Okay? There are different causes of your portal hypertension, and cirrhosis is the most important, most common intrahepatic cause, no? So, ano bang nangyayari in your portal hypertension? Well, basically, if you have that, no? In your cirrhosis kasi, di ba, there may shunting, no? May shunting. So, meron kang abnormal connection between your arteries and veins. So, na-expose yung venous system mo into the high pressure arterial system. And therefore, that can cause portal hypertension, no? And there are other mechanisms pa. But basically, if you have portal hypertension, you also have a hyperdynamic circulation. So, ang nangyari dito, nagpo-produce ka ng vasodilatory substances and it affects particular vascular beds. Now, if it affects this splanchnic circulation, you will have hepatorenal syndrome. And if it affects your pulmonary circulation, you will have hepatopulmonary syndrome. So, yung portal hypertension, ang kanyang clinical manifestations ay APES, ascites, portosystemic shunts, encephalopathy, and splenomegaly, no? Your ascites and your congestive splenomegaly because of congestion, no? And then, because of the portal hypertension, nag-open yung mga portosystemic shunts dahil dapat talaga yung portal, no? Yung portal vein, liver, hepatic vein, vena cava, yun talaga yung daan, no? For the portal blood to reach the systemic, no? Yung inferior vena cava, no? Yung papunta doon, no? Ngayon, yun yung portosystemic na connection talaga normally. Okay? Ngayon, dahil hindi nga makadaloy ng maayos doon yung blood, ang mangyayari, hanap siya na ibang daan. So, magbubukas yung mga portosystemic shunts. And ito yon. And usually, magdadilate yung mga yon. At yun yung mga varices natin. Okay? Now, for your hepatic encephalopathy naman, remember that the ammonia-rich portal venous blood should reach the liver, no, in order for it to be detoxified. Now, ang nangyayari, hindi nga dun siya dumadaan. So, nababypass yung liver. Kaya napupunta agad yung ammonia-rich portal blood mo into the systemic circulation and therefore nagkakaroon ka ng encephalopathy. Okay? So, yun yun. Now, ano ba yung hepatorenal syndrome and hepatopulmonary syndrome? So, like I said, yung hepatorenal syndrome, it happens when you have hyperdynamic circulation in your splanchnic circulation, no? So, ang nangyayari, the viscera, no, diba, the viscera, inahog niya lahat yung blood because of the increased blood flow there, no? And therefore, the kidneys are left hypoperfused. Ngayon, pag may renal hypoperfusion ka, anong na-activate? It's your RAAS. Ano effect ng RAAS? Diba? You have your angiotensin, so you have systemic vasoconstriction. Now, it affects the systemic arterial system, okay? Including the kidneys. But, because of the influence of your nitric oxide in your splanchnic vessels, they remain dilated. So, sa kanila pa rin napupunta yung blood. So, basically, nawawalan pa rin si kidney ng blood. Kaya RAAS pa rin, go, no? Systemic vasoconstriction pa rin, go. So, ang nangyayari, eventually, you will have decreased GFR. And, syempre, pagka may ganon, you will not filter your blood. No, you will not clear your blood of your nitrogenous wastes, and therefore, you will present with azotemia. And, of course, you will have also decreased urine output. No. Now, for your hepatopulmonary syndrome, ang nangyayari naman, you have your hyperdynamic circulation in the pulmonary vessels, no? So, yung pulmonary vessels mo, mas nagdadilate yung nasa base, no? Mas nagdadilate yung nasa base. So, pag nagdilate yun, there will be increased perfusion. Now, that's bad because if you have increased perfusion, no, too much of it, hindi yun ma-oxygenate adequately, no? And therefore, you will have your ventilation perfusion mismatch and you will have hypoxemia. Now, because it happens in the base of the lungs, no? When you are in an upright position, the shunting is worse, no? And therefore, the shunting is worse, no? And therefore, doon ka nagkakaroon ng difficulty in breathing, and that's what you call your orthodeoxia. And then pag pag humiga ka, no, pag nakasupine ka na, then mas mapupunta yung blood flow dun sa middle and sa upper zones, no, because balance na siya. And doon hindi masyadong evident yung shunting. Kaya gumaganda yung iyong oxygenation. Yun yung tinatawag na platip niya. Okay? Now let's go to your viral hepatitis. So, in terms of epidemiology, tandaan nyo na ang HCV, no, ang most common cause of your chronic viral hep, and you will learn why later on. So, these are usually caused by your RNA viruses except for your Hep B, which is a DNA virus. Now, the vowels are transmitted via fecal-oral route, and the consonants are transmitted via parenteral route, particularly including your sexual route. No, you know that your hepatitis D, is an incomplete particle, no, and it needs your hepatitis B to cause disease. Now, these viruses can injure the liver in several ways. Pwedeng yung immune response against it, pwedeng directly via cytopathic effect, no? And your hepatitis C, kaya siya ang most common cause of your chronic viral hep, it's because it has a low fidelity polymerase, no? And because of that, maraming errors in your replication, and nagkakaroon ka ng genetic variants, no, na marami. And that causes them to evade, no, the immune system. Kaya ka nagkakaroon ng persistent infection. Now, in terms of morphology, balik lang tayo sa chapter 2, no? So, pag inflammation, acute viral hepatitis, you see your inflammation. And since it's viral, you see your mononuclears, no? Your lymphocytes, your plasma cells. And you see cell death. Okay? But for your chronic viral hepatitis, aside from your inflammation, you see attempts at repair. You go back to your chapter 2, no? Okay? But there are some virus-specific findings like your ground glass hepatocytes in your Hep B, pneumonitis bagaga, and then your lymphoid aggregates, bile duct injury and steatosis in your HCV, the pneumonitis, your calabasa. Okay? Now, for your viral hep, we have 4 syndrome. So, you can have acute infection, no, with or without symptoms, and eventually, these lead to recovery, no? You can have acute liver failure if you're unlucky, and it's generally rare except when you have a chronic liver disease, not a background. Okay, now chronic infection, the magic number is more than 6 months. And for carrier state, you're asymptomatic but you harbor the virus. Now, let's go back again to Chapter 6. If something is chronically inflamed, then that can be a risk factor for cancer. Now, your chronic hepatitis, no, it can lead to cirrhosis, and that is a risk factor for your hepatocellular carcinoma. And actually, yung mga cancers na i-discuss natin later, most of them are, the risk factors for them are inflammatory disorders, no, of your liver and your bile ducts. Okay? So, mababalikan natin yan. Now, for your autoimmune hepatitis, sorry, may insekto. Now, for the autoimmune hepatitis, you have, of course, in keeping with the theme of your autoimmune diseases, usually they have associated autoimmune disorders again. No? Now, of course, CD8 or CD4 mediated, so T-cell mediated usually ang autoimmune hepatitis. And ang gusto ko lang i-point out, ang morphology ng autoimmune hepatitis, nag-overlap din naman yan with those of the other hepatitis. But the fibrosis is usually very evident, no, at presentation, no? And there's extensive damage. Like in autoimmune diseases, kasi nga, basically, maraming, lahat yung mga cells doon, lahat yun may antigen, no, na ina-attack ng immune system natin. Kaya usually, pag autoimmune diseases, extensive talaga ang damage, no? And some specific findings, your emperipolesis, wherein meron kang inflammatory cells within the cytoplasm of your hepatocytes, and rosette formation, no? Now, how do you diagnose your IHE, your autoimmune hepatitis? A is autoantibodies, I is increased IgG, no? H is compatible histology, and E is you have to exclude other causes. And that is because ang daming overlap in terms of clinics, in terms of morphology, madaming overlap talaga ang autoimmune hepatitis. Okay? Now, for drug and toxin-induced liver injury, so you have dose-dependent and dose-independent toxins. Okay? And they can injure the liver by being directly toxic, no, if they're directly toxic, or if they're not toxic but they're converted into a toxic form by your CYP450 enzymes, or an immune response, no, against the drug. Okay? Now, again, the morphology is non-specific, kaya nga importante ang history for your hepatitis, no? Kasi doon mo sila ma-differentiate, no? And kahit non-specific yung morphology, it usually exhibits centrizonal necrosis. So, the hepatocytes around the central vein are damaged because andun yung CYP450, no? Doon siya concentrated. Okay? Doon siya more active. And again, history of drug, elicit nyo yun para makapag-entertain kayo ng dili or tili. Okay? Now, example of this is your paracetamol toxicity. So, ang nangyayari kasi sa acetaminophen, most of the metabolism of your acetaminophen is your phase 2 reaction. So, if you recall your biochemistry, so the phase 2 reactions are responsible for that. But in excess doses, no? If you have high doses of your acetaminophen in your body, syempre yung CYP, epal yung CYP2E1. Now, that generates, no, from acetaminophen, it generates your NAPQI, and that is bad, no? That is hepatotoxic. Now, how do we combat this NAPQI? It's conjugated to your reduced glutathione to be detoxified. Now, if you have a lot of NAPQI, then that's directly toxic. And also, if you have a lot of NAPQI, you deplete yourself with reduced glutathione, which makes your liver cells susceptible to oxidative damage, no? And in alcoholics, no? In alcoholics, your alcohol induces CYP2E1 activity, kaya pakak na pakak, no, yung production ng NAPQI kahit mas konti yung paracetamol overdose mo, no, than usual. Okay? So that's it. Now let's go to your fatty liver disease. So dalawa ang causes ng fatty liver disease, no? It's either alcohol or non-alcohol. So for your alcohol, it can cause hepatocyte injury, and therefore aside from fat accumulation, it can also cause inflammation and then eventually fibrosis. So pag may narinig kayong fibrosis na naman, malamang-lamang ano na naman siya, pwedeng maka-cause ng hepatocellular carcinoma. Remember lang na yung AST at saka ALT ratio ng alcoholic hepatitis is unique such that mas mataas yung AST kaysa sa ALT, no? And that is because yung AST, no, the mitochondrial AST, no, is also released kapag may alcohol-induced liver injury ka. Kaya mas mataas yung AST. Okay? Now, for your non-alcoholic naman, usually the metabolic diseases or your type 2, DM, obesity, dyslipidemia, metabolic syndrome, no? And the insulin resistance plays a role in your liver damage because it induces a pro-inflammatory state, no? And also, the metabolic abnormalities will favor lipid accumulation, and that can also cause a pro-inflammatory state. So basically, when you have inflammation, you will have hepatocyte injury, you will have fibrosis. Okay? So, yan. Kaya ang fatty liver disease, associated siya with increased risk for your HCC, whatever the cause. Now, in terms of morphology, ang tatandaan nyo lang, steatosis, steatohepatitis, and steatofibrosis. So, basically, steatosis, fatty change lang siya. And then, pag steatohepatitis plus inflammation, no? And of course, with evidence of cell injury and death. And then, after that, steatofibrosis, may fibrosis ka na. Yun lang naman. Okay? So, ito yon. On the left, you have your steatosis. So, nakita nyo na yan in chapter 1. But kapag may inflammation na, then that's your steatohepatitis. And also, if you have evidence of cell death like your necrosis, apoptosis, or if you have cellular swelling with Mallory hyaline. Now, pag long-standing na yan, you can have your fibrosis with a characteristic chicken wire appearance. Okay? So, let's go to your inherited liver diseases. So, hereditary hemochromatosis, ang tatandaan nyo lang, it's iron excess. Okay? It's iron excess. Ngayon, ang problem with iron excess is that iron is toxic. Okay? So, when iron is toxic, okay, of course, it can injure your hepatocytes. It can cause fibrosis, no, and it can be a risk factor therefore for hepatocellular carcinoma. Now, the liver is not the only one that's affected. It's the pancreas is also affected, the heart, the skin, the joints, no, are affected. So for the pancreas, if nagkaroon ka ng pancreatic fibrosis, you can have pancreatic insufficiency, no? And when the endocrine pancreas is also involved, no, or also destroyed by the fibrotic process, you can also have endocrine pancreatic insufficiency, which presents diabetes mellitus. Now, for your heart, it can destroy your cardiac muscle, so you can have a dilated cardiomyopathy, and you can have a slate-gray discoloration of your skin, no, because of hemosiderin deposition. Now, in the liver, you can have cirrhosis, no? So, basically, yun. Now, for Wilson disease naman, the defect is that you cannot incorporate your copper into your bile. And you also have low serum ceruloplasmin levels because you need your copper for that. Now, because you cannot incorporate your copper into bile, it accumulates in the liver and it backflows into the blood and therefore is excreted in the urine, no? And that's the explanation for the triad of your lab findings of your Wilson. You have your increased hepatic copper, you have your decreased serum ceruloplasmin, and you have your increased urinary copper excretion. Okay? So basically, it also affects, it also causes damage to the liver, no? And therefore, you can, it's also a risk for your HCC. Now, aside from the liver, the brain and the eyes are affected in your Wilson. So in the brain, you can cause basal nuclei atrophy, and in the eye, no, you can have this characteristic Kaiser-Fleischer ring. Okay, now alpha-1 antitrypsin deficiency, we have already encountered this in your chapter 14, your lungs. Diba? It can cause your pan-acin or emphysema. So, ang nangyayari dito, you have you have an abnormal protease inhibitor gene, no, and that misfolded that causes a misfolded protein, no, and that misfolded protein accumulates in your liver cells and it triggers the unfolded protein response and therefore it can cause hepatocyte death. Okay, so dahil may hepatocyte injury na naman, no, at increased risk na naman siya for HCC. Okay? And syempre, pag alpha-1 antitrypsin deficiency, well, aside from liver disease, you also have to present with your pan-acin or emphysema. So that's your clue. Okay? And for hyperbilirubinemias, ayan, for alam nyo naman yun, no, we have your indirect, no, your indirect hyperbilirubinemia, yun yung unconjugated nyo, yun yung lipid soluble, and you have your direct hyperbilirubinemia, yun yung conjugated, yun yung water soluble. Okay? So for indirect hyperbilirubinemia, causes include your hemolysis, no? Hemolysis and inherited disorders of conjugation. Kaya hindi ka makaproduce ng conjugated bilirubin. So yung unconjugated ang naiipon. Now for direct, walang problema with conjugation, but the conjugated bilirubin cannot escape, no? Pwedeng may obstruction ka or pwedeng meron kang inherited disorders of impaired excretion of conjugated bilirubin. Now, in hepatocellular injury, because it is responsible for both conjugation and excretion, no, you will have a combined pattern. So, lahat sila mataas. So, clinically, these patients will present with jaundice, no? Okay? So, ano bang itsura niya? Pwede kang may bilirubinostasis. So, pwede kang magkaroon ng mga bile plugs in your canaliculi or bile deposition in your hepatocytes. Or kapag bile salts yung nag-accumulate, it can result in your feathery degeneration, no? What you call your colate stasis. Okay? So, your cholestatic disorders, meron silang increased alkaline phosphatase, but that's not specific kasi pwede yang ma-produce ng ibang disorders. But the more specific one is your GGT, no, na enzyme. Okay? Now, for your unconjugated hyperbilirubinemias, so remember the enzyme UGT1A1, no? Yan yung responsible for bilirubin conjugation. Now, in the physiologic jaundice of the newborn, no, meron kang low UGT1A1 activity at birth, and therefore, you will have unconjugated hyperbilirubinemia. Now, for breast milk jaundice, the breast milk kasi meron siyang deconjugating enzymes, kaya it causes unconjugated hyperbilirubinemia. Now, the inherited disorders are your Crigler-Najjar and your Gilbert. Your Crigler, ang type 1, severe. No, ang type 2, hindi masyadong severe. So, yung type 1, dahil severe yung deficiency, toxic siya, okay? While your type 2, meron naman, pero low lang, pero carry naman, no? Carry naman yung mabuhay. Yung Gilbert, mas mataas lang yung UGTA activity niya sa Crigler-Najjar type 2. Kasi yung type 2, 10, yung Gilbert, mga 30. So, mild disease lang siya. Pag conjugated, ang tatandaan nyo, Dubin-Johnson and Rotor. And tatandaan nyo, yung Dubin-Johnson may dark liver siya, okay? And then yung rotor, walang liver discoloration. Okay? Now, for obstructive disorders, there are different causes per age group. So, ang mga i-consider nyo in adults, stones, malignancy, and strictures if you have inflammatory disorders of your bile ducts. While for your children, for your pediatric age group, usually congenital, no? Cystic, congenital choleloccal cyst, bilat, no? Biliary atresia, and cystic fibrosis. Okay? So, basically, when you have obstruction, of course, anything before the obstruction dilates. Diba? Ganun naman. And then, syempre, pag naipon-ipon yung mga, pag naipon-ipon yung mga bile dyan, you can have a greenish-brown discoloration of your liver with resulting fibrosis then. So, that's what you call your biliary cirrhosis. So, yung mga obstructive disorders can cause biliary cirrhosis in the end, no? Okay, yun lang naman. And then, for ascending cholangitis, yan, because there is obstruction, there is bile stasis, so you can have infection, and that's what you call your ascending cholangitis. So, the common agents are your coliforms and your enterococci. So, yun nga. Anyway, pag may stasis ng secretions, no, like bile, pwede ka naman talagang pabugaran ng infection, no? Yun. So, yan yung morphologic findings niya. You have neutrophils in your epithelium and your lumen, no? So, ang clinical presentation niya ay Charcot-Chartier fever, jaundice, and your right upper quadrant pain. Now, for neonatal cholestasis, know that your physiologic jaundice, dapat nag-resolve yan by 2 weeks. Now, if the jaundice persists beyond 2 weeks, mag-entertain ka na ng diseases. So, you can have your extrahepatic biliary atresia or some non-obstructive causes. So, discuss natin yung extrahepatic biliary atresia. So, ang nangyayari, you have complete or partial obstruction of your extrahepatic biliary tree within the first 3 months of life. The most common form is your perinatal form, wherein the bile ducts are normally formed but then they get destroyed in the process later on, no, by something. And this is what you see, no, your inflammation and fibrosis, no, of hepatic or common bile ducts, which can extend up to the intrahepatic bile ducts. So here you can see your fibrosis, no, and ductular reaction and ductular bile plug. So basically ano to, infant may obstructive jaundice and malaking liver, and you need to treat them, no, you need to treat them appropriately because they can have cirrhosis by 3 to 6 months, no, if not corrected. So for autoimmune cholangiopathies, we have 2 diseases, your primary biliary cholangitis and your primary sclerosing cholangitis. For your PBC, it's more common in females, and marami siyang associated autoimmune disorders. Your Sjogren, Hashimoto's, scleroderma, no? The autoantibodies are your anti-mitochondrial. The ducts involved are your small intrahepatic. Small intrahepatic. The characteristic lesion is the florid duct lesion, which is granulomatous bile duct destruction, and that is in keeping with its pathogenesis because it's a T-cell mediated hypersensitivity reaction, no? So the diagnosis is by liver biopsy. And because it is something that happens within the liver, kasi intrahepatic bile ducts ngayon involved, that's an inflammatory disease involving the liver parenchyma, because andun yung mga intrahepatic bile ducts. It has an increased risk for HCC or hepatocellular carcinoma. Now, for primary sclerosing cholangitis naman, it's more common in males. Isa lang associated niya the disease. It's the ulcerative colitis, no? So, the autoantibody is your ANCA. You have already encountered this in chapter 13 when we discuss your vasculitis. Okay? So, the ducts involved are your large and your extrahepatic bile ducts. Okay? So, ang makikita mo doon ay sclerosing. So, ibig sabihin may fibrosis. So, you have an onion skin fibrosis around an involved bile duct. Okay? So, because it is in your the disease affects your extrahepatic bile ducts, you can have strictures throughout doon, no? Sa extrahepatic biliary tree mo. And when you do your contrast, kapag nag-intraoperative cholangiogram ka, you will see this characteristic beading of contrast media. Kasi yung bead, yung di constricted, yung tali, no, ng bead, yung constricted. Okay? So the diagnosis is by radiology, and since it involves yung extrahepatic bile ducts, no, pwede ka magkaroon ng cholangiocarcinoma na extrahepatic, or pag intrahepatic naman na bile ducts yung involved, pwede ka magkaroon ng intrahepatic cholangiocarcinoma. Okay? So, choledochal cyst. Okay? Ang clinical presentation nito, pediatric patient, may biliary colic, may mass, at may obstructive jaundice. Okay? These are congenital dilatations of your common bile duct, and these are the different types. Okay? For circulatory disorders, di ko na sila masyadong i-discuss. Pero ganito lang yan, no? Meron kasi, di ba, paano ba ang flow ng blood sa liver? From the intestines, from the portal venous system, it will go to your portal vein, it will go to the liver, it will go to the hepatic vein, and then to IVC, no? Ganun siya. So, if there's an impaired blood inflow, no, anong mangyayari? You will have portal hypertension. So, hindi siya makapunta doon. Ang mangyayari, magkakaroon ka ng congestive splenomegaly, the bowels will be congested, no, because of backflow, no, and you will have esophageal varices because of the portosystemic shunting, no, yung portocaval anastomosis, mag-o-open yan. Now, if you have impaired intrahepatic blood flow, basically may blood flow pa rin na nakakapasok doon sa liver, no, but then hindi siya nakakatuloy-tuloy, okay? And pwede ka magkaroon ng hepatomegaly na by then and liver damage, no? Because the liver suffers from congestion as well, no? Kaya ka nagkakaroon ng hepatomegaly and ng increased liver enzymes because of the hepatocyte damage. Now, if it's hepatic vein outflow obstruction, then the liver gets congested. Kaya ka nagkakaroon ng hepatomegaly, ng pain because of stretching of your liver, stretching of the capsule, no? Because yung liver nag-expand pero yung capsule hindi, no? And you can also have increased liver transaminases because of the damage, no? So, andyan naman lahat ng pathophysiology, no? So, actually, itong mga to, yan, causes na lang yan, no? Di ko na masyado i-discuss. Yan. Now, ito ang ibig sabihin lang ng peliosis, you have your sinusoidal dilation because if you have impaired intrahepatic blood flow, but then there is an obstruction somewhere along the sinusoidal network, then some of them can dilate, no? And that will cause your peliosis hepatis. Okay? Now, for your hepatic vein outflow obstruction, you have your Budd-Chiari syndrome. So, this is hepatic vein thrombosis. So, pag meron kang hepatic vein thrombosis, hindi makakadalo yung dugo papuntang inferior vena cava. It will all be behind that thrombus. And therefore, yung liver ang magsasuffer, no? Kaya ka magkakaroon ng hepatomegaly, no? Kasi nga, ang laki-laki ng liver mo. Okay? Now, tumors and tumor-like condition. So, focal nodular hyperplasia, it's a tumor-like condition. So, sa grossly, ang hanapin nyo ay yung central scar. So, yan yun. And yung central scar, punong-puno yan, marami ang vessels, no? Marami ang thick-walled vessels. So, focal nodular hyperplasia. So, of course, you will see nodularity like in this photo. You have nodules of hepatocytes separated by your fibrous septa, no? Your fibrous septae, and the fibrous septae contain your thick-walled blood vessels. Okay? So yun. Another distinguishing characteristic of your FNH is a lot of ductal reaction. Kasi ito yung i-compare ko sa kanya, yung hepatocellular adenoma. Now, this is a true tumor, no? Of your hepatocytes. There are 3 molecular subtypes, no? And ang pinakamasamang molecular subtype ay yung beta-catenin activated, which is also associated with your oral contraceptive pill and your anabolic steroid use. Yun yung classical, no? Because these beta-catenin activated hepatocellular adenomas, malalaman nyo mamaya sa hepatocellular carcinoma na yung beta-catenin yung isa sa mga oncogenes, no, or drivers ng hepatocellular CA, which explains the link between your hepatocellular adenoma and your carcinoma. Okay? So yun, morphologically wise, madaming liver cells lang ang hepatocellular adenoma. It doesn't have ductals and portal zones kasi yung FNH merong ductals and portal zones. Okay? So, for your HCC, it's the most common primary liver malignancy. As you can see, you have chronic liver disease with cirrhosis. Yun ang kanyang associated condition. So, anything that can cause chronic liver injury can predispose you to develop hepatocellular CA. And as if naman hindi pa natin yan na-emphasize ng bonggang-bongga kanina. No? Ang dami-dami na yan. So, yun lang naman, no? So, liver CA, madami siyang morphologic forms, kaya di na ako nag-bother. But this is just an example. As you can see, very atypical yung liver cells and they form these large trabecular plates. So this is one pattern, your microtrabecular growth pattern. So basically, ang hahanapin nyo in your liver CA, may chronic liver disease dapat sila na history. No? Okay. The tumor marker is your alpha-fetoprotein, and if you subject them to your CT scan, meron silang characteristic CT findings, no? Yung early enhancement of your tumor in arterial phase plus rapid venous washout. Now, liver CAs, they have poor prognosis. Okay? But there is a type of your hepatocellular CA, your fibrolamellar CA, which happens in younger patients and those with no background liver disease. Okay? And meron siyang different genetic abnormalities compared to your conventional HCC. And meron din siyang different morphology. Hence the term fibrolamellar. So, basahin nyo na lang, no? Now, kung AFP ang marker ng conventional liver CA, Usually normal to in your fibrolamellar CA. So ito yung mga, ang dami niyang difference, no? And in terms of prognosis, it's slightly better daw, no, compared to your conventional HCC. Now, the next is your cholangiocarcinoma. So, if it involves your intrahepatic bile ducts, you call them intrahepatic cholangiocarcinoma. For extrahepatic, you call them extrahepatic cholangiocarcinoma. No? Sa Robbins nakalagay biliary adenocarcinoma. Pero ito na kasi yung updated term. So your intrahepatic cholangiocarcinoma is the most common primary liver malignancy. And like your liver CA, chronic inflammation of your bile ducts, yun yung risk factor for the development of your intrahepatic cholangiocarcinoma. Now, in your extrahepatic cholangiocarcinoma, it's commonly located in the junction of your right and left bile duct wall, and that is your Klatskin tumor. Well, cholangiocarcinoma morphology is adenocarcinoma. And it's very invasive, no? Can invade lymphatic and blood vessels, and you have intense desmoplasia. Okay? So, poor din ang prognosis niya like your liver. Now, for your other tumors, basahin nyo na lang yan, but I want you to remember that the most common malignant tumor of the liver is METs. Okay? So, whenever you have a liver lesion, you always have to rule out METs first. Now, for your gallbladder naman, congenital anomaly, daanan na lang natin yan. Skip. Let's go to your gallstones. It's the most common biliary tract disease. Now, alam nyo naman yung female fat 40, that's your risk factors, no? And alam nyo naman ang clinical presentation. Usually, RUQ pain after fatty meal, mga ganon, no? So, meron tayong two types of stones, your cholesterol stones. So, ang nangyayari if you have supersaturation of bile with cholesterol plus hypomotility, no? So, yun yung pwede ka magkaroon ng cholesterol stones, no? If you have accelerated cholesterol crystal enucleation and mucus hypersecretion. So, all of those contribute to development of your cholesterol stones, okay? Now, your cholesterol stones are yellow. Okay, and they are radiolucent. Okay? Now, while your pigment stones can be black or brown, so these ones are black, so maybe they're sterile pa. But they can be brown if they're infected. Okay? So, pag pigment stones, your calcium bilirubinate, no? Calcium bilirubinate kasi yung nagko-cause niyan. So, hemolysis. Okay, hemolytic disorders, no, biliary tract infections, because these pathogens, they can break down, no, they can deconjugate bilirubin. Kaya nagkakaroon ka ng increased load ng unconjugated bilirubin na ingredient mo for pigment stones. Okay? Now, for your cholecystitis, kapag acute, usually, stones, no? Pwede kang stones or pwedeng ischemia pag acute cholecystitis. Usually, the acute cholecystitis mapupula, no? Mapupula, hemorrhagic, and you have acute inflammation. So, yun lang naman yun. Pwede ka, well, if the acute inflammation is so intense, you can have pus within your gallbladder. You call that empyema of the gallbladder. You can have full thickness necrosis, or you can have gangrene and perforation because, syempre, necrotic na yung buong wall mo. No? And you can have an emphysematous cholecystitis when you have infection by gas-forming organisms. For your chronic cholecystitis naman, of course, you have chronic inflammation, no? So you have chronic inflammation. So you see mononuclear inflammation, as you can see here in the photo, dun sa right, meron kang lymphoid aggregate sa wall, no? And you have these Rokitansky-Aschoff sinuses. Okay? So, the most common cause of chronic cholecystitis is stone. Now, gallbladder CA, it's the most common malignancy of your extrahepatic biliary tract, and the most important risk factor is gallstones. So, don't neglect your gallstones. Okay? And histology is adenocarcinoma, and like your liver and your cholangio, poor prognosis din yan. Diyos ko, parang wala pa akong magandang prognosis dun sa mga CA ng hepatobiliary. Kasi kahit yung pang CA, pangit din. Lalo na yun. Pangit ang prognosis. Okay? So, let's go to your congenital anomalies of your exocrine pancreas. The most common is your pancreatic divisum. The rest, basahin nyo na lang. Let's go to your pancreatitis. So, pag acute, dito na naman tayo, chapter 2 na naman po tayo mga be. Okay? So, pag acute pancreatitis, These are your causes, medyo madami, no? But the most common is your alcoholism. Okay? So, ang nangyayari, you injure your acinar cells, and therefore you have inappropriate release and activation of the pancreatic enzymes. And those pancreatic enzymes are very destructive, no? Remember, your pancreatic enzymes, kailangan sila for breaking down things, no? So, kapag na-release sila in a wrong site, okay, they will destroy those tissues. Okay? So, yun. And when you have tissue destruction in your chapter 1, in your chapter 2, trigger yun for inflammation. Okay? So, basically, pag acute pancreatitis, you recall your chapter 2. So, you have microvascular leak, edema, no? You have necrosis, you have acute inflammation, no? Mga ganon, no? And you can have hemorrhage if the vessels are destroyed. So, basically, yun yung morphologic findings niya. Now, depende na lang yung specifics, depende sa type, no? And the clinical presentation is your epigastric pain, a classic, no, na sudden, severe, boring, and radiating to the back, accompanied by sears and shock. Okay? And biochemically, you have amylase and lipase, no, elevated. And lipase is the better marker of the two. Okay? So shown here, you have your hemorrhagic fat necrosis in your acute pancreatitis. Nakita nyo na rin naman in chapter 1. Now, for your chronic pancreatitis, syempre long-term inflammation siya. So, because of the long-term inflammation, there is, of course, in keeping with what you've learned in chapter 2, there will be decrease in viable exocrine pancreatic parenchyma, no? Kasi, marireplace yan ng fibrosis. Now, some of the ducts may be dilated and may be filled with your proteinaceous plugs, no? And you can also have metaplastic changes because of chronic injury. Ganon. Yun lang naman siya. Okay? Now, the most common cause is your long-term alcohol abuse. Bidang-bida talaga ang alcohol sa pancreatitis. Okay? So, yun. Yun lang naman. Well, of course, dahil may decrease ka in the pancreatic parenchyma reserve, no? You have decreased pancreatic reserve. You have exocrine pancreatic deficiency, and you will present with malabsorption disorders, no? Particularly your pancreatic maldigestion, yun talaga yung strict term for that. And then, syempre, maapektuhan din yung endocrine pancreas eventually if you have severe, no? If you have severe fibrosis or extensive fibrosis. Of course, magkakaroon ka din ng parang DM. Now, it's worth noting that your hereditary pancreatitis with your PRSS1 mutations, they have 40% lifetime risk of developing pancreatic CA. Now, for your pancreatic pseudocyst is the most common pancreatic cyst. Now, ang nangyari kasi dyan, if you have some necrosis, no, na nangyari, tas nag-heal yun, basically, ma-enclose yun ng fibrous tissue. So, yun, kaya ka nagkakaroon ng parang cystic lesion. Now, it's called pseudocyst because it doesn't have a true lining, no? Now, pwede naman tong mag-regress. It regresses most of the time. But syempre, kapag medyo malaki, medyo mahirap namang mag-regress. And also, syempre, may fluid na maaano doon. The fluid is static, no? And therefore, can be infected. Okay? So, pwede rin yung mag-perforate. Pancreatic ductal adenocarcinoma, yan. It's commonly a disease of the elderly, and please take note that smoking is the most important environmental risk factor, and KRAS is the most frequently mutated oncogene. In terms of morphology, it's adenocarcinoma, so glands, no? And it's highly invasive with intense desmoplasia. Okay? So, ang symptoms niya, depende sa location. So, most common sa head. Pag nasa head siya, magpaproduce ng obstructive jaundice because nandun yung common bile duct, no? Kaya magkakaroon ka ng obstruction doon. And you will also have this Courvoisier sign, no? A palpable gallbladder, no? Now, for body and tail, malas mo. Okay? Kasi, dahil walang obstructive jaundice na mangyayari, hindi mo alam na meron ka palang mass doon, no? And that's the reason why tridor, no? Tridor ang pancreatic CA, especially if it's in the body and the tail. Because nadedetect mo sila kapag advanced na sila. And also, your pancreas is very close to your great vessels. Kaya, Diyos ko, good luck. And talaga, kaya ang bilis niya kumalat, no? Yung hindi mo na nga ma-detect, bilis pa kumalat, ang lalala, no? And the tumor marker is your CA19-9, and sadly, pancreatic ductal adenocarcinoma is fatal in almost all cases. So that ends your HBT Panc chapter. Okay, sunod-sunod rin na natin ang mga toxic na systems. Kidney. Okay, skip that. Let's go to your nephritic syndrome, no? So, may mga tanong talaga doon. Ano yung nephritic, ano yung nephrotic? So, kailangan malaman yung difference between the two. So, pag nephritic syndrome, so nephritis, itis, no? So, meron siyang inflammation, no? And because of the inflammation, you destroy your glomerular filtration barrier. And that causes hematuria more than proteinuria, no? So, hematuria yung classic for nephritic syndrome. Well, because of that, you will have obliteration of your capillary lumen, and that obliteration will cause the decrease in your GFR. And that clinically will present with your decreased urine output. And of course, since you have decreased GFR, then you cannot clear your nitrogenous wastes in your blood, and they will be present in your blood. And that is what you call your azotemia. Now, because you cannot excrete urine, no, magkakaroon ka ng fluid retention, and that explains the edema and the hypertension. Classic example is your PSAGN. It's the most common cause of nephritic syndrome in children. So it's a non-suppurative sequelae or a sequela of your beta hemolytic strep infection, and it's a classic type 3 hypersensitivity reaction, as you have learned in your chapter 5. Now, meron kasing something in your streptococcus, that's your SPEB, no? And that can directly activate your complement. So when your SPEB is in your glomeruli, no, that can directly activate complement and cause glomerular damage. Or pwedeng it can form an immune complex and get deposited in the glomerulus, and pwede ka magkaroon ng inflammation there, no? The classic type 3 hypersensitivity reaction. So in terms of morphology, sa light microscopy, tandaan nyo lang na hypercellular glomeruli siya, no? Which indicates an acute process. And the hypercellularity can be because of proliferation of the cells here or infiltration of your inflammatory cells. So in this case, in this picture, marami kasing leukocytes there, kaya mukha siyang hypercellular, no? Well, because of the inflammation, your capillary luminas are obliterated, no? And tandaan nyo in your PSAGN, mga buzzwords, subepithelial humps on your GBM. Now, if you do your immunofluorescence, you will see IgGC3, no? Pag magkatandem yung IgGC3, ibig sabihin, immune complex mediated yung disease. Okay? So, nephritic syndrome nga siya, no? And usually it occurs 1 to 2 weeks after recovery from your streptococcal pharyngitis, no? Now, may azotemia ba sila? Sa children, usually wala. Sa adults, usually meron. Kaya ang PSAGN, pag adults, toxic, no? And then, you will have, of course, your anti-streptolysin O and anti-DNase B. Kasi as you have learned in your chapter 11 in your acute rheumatic fever, di ba? These are markers of your previous or antecedent streptococcal infection. Now, the C3 is decreased because they're used, no? They're used in the formation of your immune complexes, no? Kaya they have low blood C3 levels. Now, like I said, okay ang PSAGN pag child, no? But for adults, pag nagka-PSAGN ka, toxic yon. Usually, sila yung nagpo-progress into chronic glomerulonephritis. The next one under nephritic syndrome is your RPGN. Now, ito yung definition ng RPGN, and we have 3 types, no? One is for anti-GBM antibodies. Two is for secondary, no? So it's a secondary event of your immune complex mediated glomerular injury, and then 3 is for your ANCA vasculitis. Okay? So ang nangyayari in your crescent, bakit ka nga ba nagkakaroon ng crescents in your RPGN? It's because nagkakaroon ka ng rupture in your glomerular basement membrane, and yung mga growth factors, no, nagli-leak into the Bowman space, no? Kaya na-expose yung mga parietal epithelial cells ng yon na-expose sila to the growth factors, kaya sila nagpo-proliferate. And the result is a crescent, no, that can obliterate that can compress your glomerulus. Now, if you compress your glomerulus, your capillary tufts will collapse, no? So, magsha-shut yan and therefore you will have low GFR. No? So, basically yun. Yun yung nangyayari. Low GFR or liguria. No? Now, yun yung makikita mo sa light microscopy. Now, in your EMs, of course, you will see your ruptures in your glomerular basement membrane. Okay? And for type 1, you will have a linear pattern of immunofluorescence. Makikita nyo yan later. For type 2, you have your granular kasi yung ibang immune complex-mediated nephritis, granular din ang deposits nila. So, in keeping with the secondary nature of your type 2 RPGN, no? As a complication of your immune complex-mediated nephritis. And then your type 3, syempre, negative, no? Ancavasculitis tong mga to. So, wala kang immune complexes. Okay? So, for your Goodpasture syndrome, it's a type of your type 1 RPGN. So, ang classic nito, 20s, smoker, male, and meron kang hemoptysis and nephritic syndrome. Okay? And because it's a disease due to antibodies against your collagen type 4. And the reason why there is both pulmonary and glomerular involvement is because it's a common antigen shared by those two. No? So, yun. And then, nakikita nyo here, meron kang linear pattern of immunofluorescence. Kasi, syempre, yung collagen type 4, uniformly present yan across the basement membrane. So, yung buong basement membrane, nagla-light up. Okay? So, yun. Yun ang kanyang clinical picture. Nephrotic syndrome naman tayo. So, pag nephrotic syndrome naman, more of proteinuria ang problem. No? And because of the proteinuria, you lose your albumin. No, you have increased renal loss of your albumin. So you will have hypoalbuminemia. And you know, in your chapter 3, that when you have hypoalbuminemia, you will have decreased plasma oncotic pressure and you will have edema. Now, you also lose your globulins and therefore you're susceptible to infections. You also lose your anticoagulant proteins, which predisposes you to a hypercoagulable state. And because nagkakaroon ka ng collateral increase in your hepatic lipoprotein synthesis, you can have hyperlipidemia and therefore lipiduria. No? Yung lipiduria na yan, mamaya ma-discuss natin here, no, in your minimal change disease. So for MCD, it's the most common cause of nephrotic syndrome in children. And usually, ang hahanapin nyo sa history, meron silang post-respiratory infection o kaya post-vaccination, tapos nagka-nephrotic syndrome, no, nagka-proteinuria. Okay? Or pag adults, usually meron silang blood malignancy. Okay? So, ang tatandaan nyo sa minimal change disease, normal ang glomerulus, minimal change, no? Walang change in terms of light microscopy, but a common finding in all nephrotic syndromes is the effacement of your foot processes, no, of your visceral epithelial cells. So, tandaan nyo lang yon. And then, wala ka ding immune deposits. Now, the clinical picture of minimal change diseases, yun nga, child, post-vaccination or post-respiratory infection, may nephrotic syndrome ka, but then, wala kang azotemia. So, walang increase ng BU-NCREA, no? And if you subject them, no, if you make them take steroids, no, magre-respond sila. So magre-resolve yung nephrotic syndrome, and also the morphologic changes will subside, no, will return to normal. Now, yung sinasabi ko na lipiduria in your nephrotic syndrome, it appears morphologically as your lipoid nephrosis. Kasi nga dahil daming lipid doon na dumadaan sa kidney, nade-deposit din sila doon sa mga proximal tubule cells. Now, for your membranous nephropathy, it's the second most common cause in adults because the next disease is the most common, no? So, this is the second most common, and these are the associations, so tandaan nyo na lang sila. So, remember in your primary membranous nephropathy, your antiphospholipase A2 receptor antibodies, yon, tandaan nyo siya. Yun yung most common. Okay? So, ang tatandaan nyo sa membranous nephropathy, thickened yung kanyang capillary wall. Kaya ganito yung itsura niya. Very pronounced yung kanyang capillary wall, as you can see here in this photo. And ang buzzword dito ay yung spike and dome appearance. As you can see, it's a common finding, no, yung effacement of your foot process in your nephrotic syndrome. Okay? So, usually, wala din silang azotemia like your minimal change disease. But the difference is, aside from this, more commonly happening in adults, it's not steroid responsive. For your FSGS naman, it's the most common cause of your nephrotic syndrome in adults in the US. Remember that it is associated with your HIV and your sickle cell disease. Okay? So anyway, pwede kasi itong primary or pwedeng secondary event of your other nephritis or any diseases that can cause insignificant renal parenchymal loss. Well, kasi, syempre, kapag for renal loss, kunwari, if you have diseases na, nagre-result in increased parenchymal renal loss, ang nangyayari, your remaining glomeruli compensate, Pag nag-compensate sila, basically, pag na-overwork sila, ang mangyayari, magiging sclerose din sila in the end, Kaya yun, nagkakos ka ng FSGS dahil dun sa mga ganong, diseases, And then, yung iba naman yung kanyang mechanism. Okay? So, morphologic-wise, ang i-expect mo, may sclerosis, may hyalinosis, Tapos, yung collapsing FSGS, yan, it's, tandaan nyo siya kasi kagaya dito sa picture na to, pag sinabing collapsing, kasi dapat itong glomerular tuft, halos lahat naka-fill up dyan. Naka-fill sana yan dun sa buong space. Kaso nga lang ito, parang nagko-collapse na siya. So, parang siyang nag-retract. So, remember that, kasi yan yung most characteristic lesion ng HIV-associated nephropathy. As you can see, andyan pa rin si diffuse effacement ng foot processes, common in all nephrotic syndromes, Okay, and yan, ang tatandaan nyo sa FSGS, compared dun sa MCD at saka dun sa MN, meron siyang azotemia. Okay, so it's also not steroid responsive, and if may FSGS ka, it tends to run a progressive course. Now, for MPGN naman, ayan, madami kang associated conditions. Okay? And if you look at the pathogenesis, it's immune complex. So, makikita mo na naman si IgG-C3 magkakatandem na naman together with your C1q and C4. Kasi kung immune complex yan, it means classical pathway of complement, if you recall your chapter 2. Ang tatandaan nyo here na keyword ay yung tram-track appearance of your glomerular basement membrane. Yun yung keyword sa kanya. Now, the deposits in your MPGN type 1 tends to be located at the subendothelial area. So, it can present either with nephritic or nephrotic syndrome. It has a slowly progressive, unremitting course. And this is your MPGN type 2. So, this one, alternative complement pathway, Alternative complement pathway ang, ang kanyang pathogenesis. And it is reflected, It's reflected in your immunofluorescence findings. Kasi meron ka lang C3, which is in your alternative pathway. But you don't have Ig, C1q, and C4, which are involved in classical complement activation. Kaya, para matandaan nyo siya, kailangan alam nyo yung principle ng complement. Okay? So, compared doon sa MPGN type 1 na ang deposits ay subendothelial, ang deposits ng dense deposit disease ay nasa intramembranous, It's intramembranous in location. Okay? The prognosis is poor. IgA nephritis, The Berger disease, your IgA nephropathy, it's the most common type of glomerulonephritis worldwide. Yan. So, ang nangyayari dito, IgA nephropathy nga. Because there's an abnormal IgA that deposits in your mesangium and it triggers an immune response. Okay? So, nagkakaroon kayo ng immune complex formation. Sa glomerulus siya nagde-deposit. Okay? So, anything IgA, mesangial, And you have your, ayan. And ang clinical presentation nito, you have hematuria after a respiratory tract, GIT or GUT infection. So, yun yung tatandaan nyo, ha? Okay? Now, in terms of prognosis, variable siya, but these are the clues ng increased risk of progression to chronic renal failure. If you had it in old age, if you have heavy proteinuria, you have hypertension, or you have a very extensive glomerulosclerosis on biopsy, no? So here we have a picture of your IgA nephropathy. So hina-highlight nga yung IgA deposits in your mesangium. Okay? Now, yung Berger disease kasi IgA nephropathy lang siya. Now, if there is systemic abnormal IgA deposition, that's your hinoxon line purpura. It's common in children then. And aside from the renal findings, you have palpable purpura as you can see in the photo. And you can have GIT and musculoskeletal complaints as well. Okay? For your Alport syndrome, it also deals with your type 4 collagen like your good pasture, no? But this one is an inherited disease. Okay? So, ano bang meron sa kanya? For the keywords in the morphologic findings of your Alport syndrome, it's the basket weave appearance of your GBM, no? So, aside from the renal findings, the most common is your hematuria, no? Hematuria and then progressing to renal failure. No, meron siyang ears and eyes. So, meron siyang deafness, no? Meron siyang deafness and meron siyang lens dislocation, posterior cataracts. Okay? So, ang ano ko dyan, ano yon? Bingi, bulag, may blood ang urine. Yun ang ano ko dyan sa Alport syndrome. Tapos, yung, in terms of prognosis, pangit. Okay? Yung thin basement membrane nephropathy, nasa type 4 collagen din siya, no? Kaya close mimic siya ng Alport. Kaso nga lang, imbis na yung basket weave appearance, no, ang sa kanya, thin yung basement membrane, no, ng GBM. And the prognosis is excellent. Compared dun sa Alport, yung Alport kasi pangit ang prognosis. Yung thin basement membrane, maganda. Okay? Now, let's go to your tubulointerstitial diseases. So, first off, we have our ATI or ATN. No? So, we have two causes of this. No? Either ischemia or exposure to toxin. So, they have different features. But here, we have a picture of your acute tubular necrosis wherein, because of the insult, nagkakaroon ka ng sloughing off ng epithelial cells. Okay? And then, nagkakaroon ka din ng mga cast na bumabara doon sa tubules mo. Kaya nagkakaroon ka ng acute kidney injury, no? Because of the casts. And yan. Clinically, ang una mangyayari dyan is mag-decrease yung urine output mo and then biglang bubulusok na siya, no? With the other abnormalities like your azotemia, the electrolyte abnormalities, and all that. And then magre-recover ka. So, meron ka muna, and then mag-increase na ulit yung urine output mo and then eventually mag-normalize ka na, no? Now, the prognosis depends, of course, on the magnitude and the duration of your ATI. Now, the next most common cause of acute kidney injury is your drug and toxin-induced tubulointerstitial nephritis. So, again, pagka ganito, you have to elicit the history of the intake of these meds, and then usually it happens 2 to 40 days after exposure with fever, eosinophilia, and rash, and your renal manifestations. Okay? So, drug withdrawal will cause recovery naman, but slow. So, for NSAID naman, ang nangyayari, yung NSAIDs kasi, di ba, the COX-2, may COX-2 kasi na dun sa kidneys. Now, yung mga yun kasi, nagpaproduce yun ng prostaglandins. Tapos yung prostaglandins, di ba, vasodilatory sila. Now, if you have NSAIDs, no, they will inhibit yung COX-2 and that will cause decrease in the vasodilatory prostaglandins. So, magkakaroon ka ng renal ischemia and then, yun, parang ischemic ATN ang labas, no? Parang ganun siya. Now, there are other forms of injury ng NSAID-induced nephropathy which are the following. Now, for urate naman, if you have gout, if you have chronic hyperuricemia, now acutely, those crystals can precipitate and obstruct your tubules and can lead to acute kidney injury, or they can deposit as tophi. No? Pwede ka magkaroon ng tophi in chronic urate nephropathy, and pwede ka magkaroon ng fibrosis there. No? And pwede ka din also magkaroon ng uric acid stones. Now, for your myeloma naman. Now, your myeloma, remember, in your chapter 12, we have discussed myeloma. So, it involves the production of your monoclonal immunoglobulin, no? And these are your light chains. Now, your light chains are direct, as I said, no, in chapter 12, they're directly toxic to your epithelial cells. Now, also, these light chains can organize with your TAM horseball protein, no, and become casts that can obstruct your tubules. Now, bakit ba yung tubular obstruction ay napaka-importante? It's because your tubules, no, kailangan free-flowing yung urine dyan. Kasi kung meron ka obstruction dyan, anong mangyayari sa pressure sa urine space ng glomerulus? Tataas. And therefore, it will not favor glomerular filtration. No? Tandaan nyo ang chapter 3 nyo. Tandaan nyo yung chapter 3. Now, your hemodynamics. Okay? So, because of that, bababa ang GFR. No? Kaya nagkakaroon ka ng kidney problem. Okay? Now, aside from that, your light chains can deposit, no, in your tubules, in your basement membrane, in your GBM or tubular basement membranes, and can be an amyloid also. So, renal amyloidosis. So, yon, ang dami-daming pwedeng mangyari in your myeloma sa kidney, no? So, pyelonephritis and UTI. So, pyelonephritis. It affects your tubules, interstitium, and your renal pelvis. Now, it's more common in females and in 1 to 40 years old, but it's more common in males with advancing age, no? Kasi may prostatic hyperplasia sila. Yung females kasi meron silang shorter urethra, so mas mabilis, no, makolonize yon. Okay? But for males, diba, if they have prostatic hyperplasia, they will have urinary retention, and yun yung risk factors mo. So basically, anything that can promote infection will cause pyelonephritis, no? Is a risk factor for pyelonephritis. The most common etiologic agent is your E. coli, no, and your followed by your Proteus. So basically, it's an ascending infection. If you have urethral infection, then it ascends, no? And then if you have reflux mechanisms, no, which will allow reflux of your infected urine, no, back to your upper urinary tract, then nakakarating sila sa kidneys. Now, in the kidneys, the upper and the lower poles are the most commonly affected because of the conformation of your renal calyces there, no, your pelvocalicial system there. Kaya doon nagkakaroon ng scars in your chronic pyelonephritis. Now, in terms of acute and chronic, in terms of morphology, tatandaan nyo lang na for acute, it's usually the inflammation and the tissue damage that's more evident. But for your chronic, it's the fibrosis, no? It's the fibrosis that's more evident. And you see this characteristic thyroidization, no, of your tubules in your chronic pyelonephritis. In terms of clinical presentation, pag acute, no, in keeping with the lessons that you have learned in chapter 2, no, pag acute usually systemic symptoms, no, you have your fever, you have pain, diba? And you can have pus in your urine, which is in keeping with acute inflammation. And then for your chronic, since there is decrease in your viable renal parenchymal reserve due to extensive scarring, you can have renal insufficiency. Well, the vessels are also affected by that, so you can have hypertension, and you can have repeated bouts of acute pyelonephritis. Okay? So these are the complications of your acute pyelonephritis. You can have necrosis of your renal papilla. You can have abscesses, no? But for your chronic, syempre, it has something to do with fibrosis. So you have secondary FSGS, and you know that FSGS can eventually progress into ESRD. For your nephrosclerosis naman, so na-discuss na natin to, no? Diba? You have your hypertension, your DM, it will cause your hyaline arteriolo-sclerosis, no? Yun yung maano mo sa kanya. Now, grossly, ang ano sa kanya, ang characteristic sa kanya is the leather granular appearance. Okay? But in your nephrosclerosis, remember that your uremia and your renal insufficiency is uncommon except for the following patients, no? African patients, malignant hypertension, and diabetes. For renal artery stenosis naman, now these are the causes. Now, anong nangyayari for, the most common is your atherosclerosis, okay? So, anong nangyayari? If you have renal artery stenosis, you have renal hypoperfusion, and kanina mo pa naririnig yun, you will have increase in RAS activity, and that can cause your secondary hypertension, no? Kasi you retain sodium in water, and then you increase your vascular resistance because of angiotensin, no? Now, the ipsilateral kidney will suffer more from ischemic changes, okay? While the contralateral kidney will suffer from the effect of hypertension. Okay? So, sila yung may arteriolosclerosis. Okay? Gets nyo kung bakit? No? Kasi, the stenosis protects, no, the ipsilateral kidney from the hypertensive changes. Okay? Now, for your renal infarcts, well, na-discuss na naman natin yan in your chapter 3. So, basahin nyo na lang yan. Then we also have our nutcracker syndrome, wherein the left renal vein is compressed by the superior mesenteric artery anteriorly and the abdominal aorta posteriorly. So dahil nakakat niya yon, nagko-congest yung mga organs na drained by the renal vein, and that includes your kidney, no? That includes your left gonads, no? And you can also have pelvic varicosities. Basta puro left, no? Puro left yung manifestations niya. Now, for your cystic diseases of the kidney, the common pathogenesis is there is altered function, no? Altered ciliary function, no? And yung ciliary function kasi na yon, connected siya sa calcium channels, no? Connected siya sa calcium channels, such that when you have those abnormalities, basically nagkakaroon ka ng increase in calcium influx, no, into the tubular epithelial cells. And you have learned in the previous chapters that your calcium is like a key to a lot of metabolic processes. So nangyayari yang cell proliferation, the fluid secretion, no, and that can cause your cysts. So in your ADPKD, these are your defects, no, your polycystin 1 and your polycystin 2. And remember the yung associations niya, no? It's associated with your liver cysts, no? Brain aneurysms, no, your intracranial berry aneurysms, and your mitral valve prolapse. Now, this is the appearance of your ADPKD, no? Pag autosomal dominant, sobrang sira-sira yung kidney kasi ang dami niyang cysts, no? So bumpy yung kanyang surface. Okay? For ARPKD naman, it's fibrocystin, that's the defect. And these patients, they have renal failure in infancy, and when they survive, yung congenital hepatic fibrosis yung nagiging presentation nila. Okay? If you look at the kidneys, they're smooth externally, but you will see, no, in your cut section, you will see dilated medulla, no? And dilated collecting ducts, sorry. Okay? So, but the surface is characteristically smooth as compared to this, no? Yung sa ADPKD, rough, bumpy siya gawa ng cysts, dito smooth. Okay? So, urinary tract obstruction. So, there are a lot of things that can cause obstruction in the urinary tract depending on the level, no? Kung urethra, bladder, ureter, no? Meron yan, no? There are a lot. Okay? But basically, when you have an obstruction in your urinary tract, basically the pelvocalyceal system will dilate, and that's what you call your hydronephrosis. Now, because of that, no, it can exert atrophy, no, pressure atrophy, no, on you against your normal parenchyma, kaya nagkakaroon ka ng progressive renal atrophy as well, no? Okay? So, syempre may urine stasis ka dito. So, pwede ka magkaroon ng susceptibility to infection. There are also stasis of some elements that can enable stone formation, no? Now, for urolith, pag urolith, ano siya? Painful hematuria. Okay? Painful hematuria. And what is the most important factor in the development of your stones? It's supersaturation. Also the pH, no? The pH determines kung anong stones yung mga ma-favor na mag-form. Also, if you have low urine volume, no? Syempre, concentrated, no? Concentrated yung mga substances that can form stones. And if you have infection, I will discuss later on, one stone that is associated with an infection, no? It can also enable stone formation. The most common type is your calcium stone. So, ito yun. They form in acidic urine, no? And ganito yung itsura niya, octahedron, no? your struvite forms in basic urine. So, tandaan nyo yon. And it's associated with proteus infections. Remember, your proteus has urease. So, kino-convert niya yung urea into ammonia. So, nag-increase yung pH, nagiging basic, and it enables it favors formation of your struvite. Now, your struvite, no, your MAP crystals can, form your staghorn calculi kasi yun yung malalaking stones na nagfi-fit dun sa shape ng pelvocalicial system. Okay, so yun. Tapos, yung uric acid naman, di ba kanina nabanggit natin yung urate nephropathy, you can have uric acid crystals, no, in your urine. Okay, so when you have your hyperuricemic states or diseases with rapid cell turnover like leukemias, so ganito yung itsura niya. And when you have cysteine, it also forms in acidic pH if you have your cysteinuria, no? And these appear as colorless hexagonal plates. Okay? Now, for your malignant tumors, the most common is your renal cell CA. The second most is your Wilms. And the third is your urothelial carcinoma of the pelvocalicial system. And these urothelial carcinomas, they have poor prognosis. Remember that. Okay? Now, for your renal cell CA, it's commonly disease of the elderly, common in males. And the most important risk factor is smoking, and there are other things that are associated with that. So, basahin nyo na lang siya. Now, how do you recognize renal cell carcinoma clinically? Hematuria, flank pain, and mass. You have hematuria, flank pain, and mass. And it has a lot of paraneoplastic syndromes. Okay, so tignan nyo na lang din yan. Now, remember that your kidney is a very vascular organ, and therefore, it's one of the cancers that characteristically disseminates hematogenously, no? Okay? And kung renal vein invasion is common and therefore makalat ang renal cell CA, so yun nga, pwede ka magkaroon ng early mets because when it invades the renal vein early, then you can have systemic dissemination or distant mets, no? Even before maging apparent yung tumor. Okay, the most common metastatic site is the lung. Okay, followed by the bone. So we have three histologic types. Now, your renal cell is the most, your clear cell renal cell or the CCRCC is the most common type. What is the syndrome associated sa kanya? It's the von Hippel-Lindau disease. So, diniscuss natin yan in your chapter 10 in your blood vessels. So, it's derived, it arises from the proximal tubule cells. So, yun ang itsura niya, clear cells. For your papillary renal cell CA naman, you have papilla, no? You have papillary structures. So, associated naman sa kanya ay yung fumarate hydratase deficiency, no? Yung which can cause your hereditary leiomyomatosis and RCC syndrome. Tapos, yung hereditary papillary carcinoma. So, kung ang clear cell carcinoma derived from proximal tubule cells, ang papillary renal cell derived from distal tubule cells. So, yun ang itsura niya, papilla lang naman. No, it's the second most common. Now, yung third most common is yung 5% of cases, yung chromophobe renal cell carcinoma. Yung associated naman sa kanya ay yung Birt-Hogg-Dubé syndrome. So, ito yung components niya. And yung isa proximal, yung isa distal, ito sa intercalated cells of collecting ducts naman siya. Thought na nag-arise. And then, yung itsura niya, you have your pale eosinophilic cells with a perinuclear halo like so. Okay? So, yan. That ends our kidney.